It's already 5 p.m. Should we start with today's session?
Yes.
Yes, from now on.
Okay.
Yes.
Okay. So greetings and a warm welcome to all the dignitaries present here. I'm Swastika from Team Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet is India's most trusted and widely used digital platform, offering a multitude of enhancing services exclusively for doctors. Clarinet is elected to be chosen as a digital partner for this event organized by Association of Fellow Gynecologists Mumbai. So today's focus would be AFG Yuva webinar. So let's begin today's session, for which I would like to invite Dr. Monica ma'am. Over to you, ma'am.
Good evening, everyone.
Good
I welcome
evening. Hi.
I welcome you all for the second Yuva webinar. Much more better and again new topics for all the young people around. Um, on behalf of Dr. Nitin Shah sir, our president, our secretary Dr. Bela Bhatt madam, our treasurer Dr. Jayanti Kamath madam, and all our office bearers, we shall start the session. Uh, I would invite Dr. Bela Bhatt madam to just give a few words before we start the session.
Thank you so much, Dr. Monica. Well, I extend a warm welcome to each and every one of you on this second Yuva webinar of Association of Fellow Gynecologists. Our Yuvas are rocking and they have done a wonderful job in the first webinar as well. And today we have Dr. Pranita, Dr. Ankesh Sahitya, Dr. Rashika, Dr. Purva, Dr. Anand Nanavati, Dr. Samil Trivedi, and Dr. Shweta Mishra, who are going to talk on various topics of postnatal mental health and ovarian rejuvenation and endometriosis and laparoscopy and embryo and whatnot, IVF, etc. So I'm sure this webinar is going to be beneficial to all of you all. So first of all, I congratulate all the speakers for showing interest in this wonderful webinar. And I think let's welcome the first speaker and start with her academics. Yes.
Swastika, can you So, good evening, everyone. The first speaker for today is Dr. Pranita Bankar, madam. She is a consultant at Malad East Divine Care, also a DNB teacher at BDBA Shatabdi Hospital. Without wasting too much time, let's start the session. And over to you, ma'am.
Thank you, Monica, and thank you, Bela Bhatt madam and Nitin sir and entire AFG to give us this opportunity. Can you share my slides? So, good evening, all of you. And today, it was my pleasure that the sir had given us opportunity to choose the topic, and I chose perinatal mental health problem. In today's era where everywhere there is talk about laparoscopy and IVF and lot many things which are coming new, I decided to go a little bit on the drier side of the topic. Why I chose this particular topic is because in last 6 months I have seen many cases in my OPD and my hospital coming with mental health problems. So I decided to have a little bit discussion on this so that everyone is aware, and our goal is to recognize those symptoms and help the women and the family to have nice and smooth journey in this pregnancy, in the pregnancy and post pregnancy. I'm just sorry.
Ma'am, should I move to the next slide?
Yes, please.
Okay.
Minute. Yeah. So, what is perinatal period? What perinatal period is described as emotional and psychological well-being of an individual in and after the pregnancy, and the postnatal period typically is up to 1 year. Next, please. And as I told you, in my personal experience also says so that there is a huge number that has increased in women with with mental health problems. And RCOG, WHO, and SOG, almost this data is taken in 2022. 1 in every 5 women is experiencing a mental health problem. Next. WHO in 2022 said that in 10% of the pregnancy, when patient is in antenatal, woman is in antenatal period, 10% of the women is suffering from some mental health issue, which increased to 13% post-delivery. And this is the data worldwide. If we come to, we think India is a social country and there should not be any thus such kind of problems. But on the contrary, if you look at the data, in developing countries, the data is much more, the number is much more, that is 16% in pregnancy and approximately 20% post delivery. And most common, if we see, it is a depression which occurs in first year post delivery. Next. And all these problems, because the women is not able to cope up with, apart from, we are always focusing on the maternal mortality due to preeclampsia, abortions, septic abortions, or postpartum hemorrhage, cardiac events. But if this is the silent killer, which you can see on the slide, 20% deaths are due to suicide. And if we offer a proper support and care throughout the pregnancy, these deaths can be avoided. Next. So there was a beautiful article which was published uh, by Disha Shetty, that she said in 2022, India is trying to reduce the maternal mortality without addressing a key contributor, suicide. She also took some data, and in that it was noticed that southern states of India, that is particularly in Kerala, though the maternal mortality due to other causes has reduced and it is considered a safest place to give birth in over entire country, but deaths due to suicide has increased from 4%, 2% to 20% in 2020. So that's a huge number which has increased, though the other numbers due to the causes of the maternal mortality has reduced. So it is a time that we have to address this mental health amongst pregnancy and postpartum very seriously. Next. Key factor in reducing this mortality due to mental health problems is understanding the mental status of the patient and the family, and that happens right from the preconception till the delivery, till even after the delivery, and addressing the need and the treatment at the earliest. Next. So as I just told you that I have myself found 6 cases of such kind. The first case that I wanted to tell you is this was my own registered patient who underwent an elective LSCS at 38 weeks for GDM, and she delivered a 4 kg female child. Everything was normal post-operatively and she went home happily. Day 10, when she came for suture removal, she was not talking to the way she usually talks to me, or there was no eye contact. She was very little upset. So I asked. Initially, she was not ready to talk. Then I sent the husband outside. And on inquiry, she told me that because of the girl child, the family is not happy. So she's alone, and the husband is alone taking care of the child, and there is no support. And she is not able to eat properly or sleep properly. So this is a key issue that I had to dig into. Patient will not tell you all these things on her own immediately. So you have to take those extra minutes to talk to the patient and get out what is there inside her mind. So this was the first case. So I offered her immediately psychological evaluation and counseling. This patient settled with only counseling only. She never needed any pharmacological medicines. So I always call this case as a case of postpartum blue to mild depression. Case 2. Next slide. This was a case. This patient, I had not seen her antenatal in my antenatal period. She was referred to me by one of the consultant for cesarean section, and she was 38 weeks. The entire family was there while patient was admitted. We delivered a female baby. It was a very uneventful. Entire family was happy. They celebrated also. Patient was discharged, and then again when she came for suture removal, patient was upset. There was breast engorgement slightly, and I asked her what was the reason. So she told me that she had to give because of the family uh, problems, circumstances, because her sister was not able to conceive. She had to give that baby to her sister, and that's the whole purpose of this pregnancy. This entire discussion the patient had was already aware about, and patient was a part of discussion. She had made the decision herself. So here things that are coming that throughout the pregnancy, though she was firm on her decision, but after the delivery, because of the baby attachment or the relationship she bonded with the baby, she was not able to cope up with the fact that she had to give the baby, and she was not eating well. She has also lost weight. She is not able to sleep. So with the family, I called the family next time for the counseling, and we offered her psychiatric evaluation, and she was started with antidepressants. So this was a case of postpartum depression. Case 3, next slide, please. Next slide. This was an interesting case. This patient, 38-year female, and the male was 39-year. Couple was anxious to conceive. They had previously one failed IVF cycle. Again, they were trying to conceive. They came to me, and we did the second IVF cycle, and patient conceived. At 6 weeks, patient had one mild episode of spotting, where in which she rang me over phone that doctor, I'm having a spotting. I told her we can get the scan done. We got the scan done. Everything was nice, and the baby activity, heart activity had also come. So I told her nothing to worry. Just put her on bed rest, increase some doses of progesterone, and she was doing well after that. At 8 weeks, patient comes to me. This time in OPD, she's not talking to me very openly. She's having a little bit of low mood that I could notice. And she told me, doctor, I don't want to continue this pregnancy. There, I got a little shocked, though I did not show it on my face, but inside, obviously, after 2 IVF cycles, such so many injections, why this patient is telling now she doesn't want to continue the pregnancy. Now what? I asked her questions regarding her family background. Is there anything wrong in the family? Any family husband dispute, any husband, any work stress? She said nothing like that. I just don't want to continue the pregnancy. And she also told me that at 6 weeks when I had a spotting, I was just hoping that baby acha nahi rahe. But that didn't happen. And then I said, it might be hormonal. You might be just feeling because there is a peak of hormone that is happening to you. So you can get a counseling done. And I sent her for psychological evaluation and psychiatrist also. Since we had whatever decision she had to make, there was a little window left. So we had to put her on antidepressants. Initial diagnosis made was adjustment disorder. So she continued the treatment with antidepressants also and counseling and meditation. At 11 weeks, she did NT scan, double marker, everything was normal. Again, after 3 weeks, the patient turns up, says, I don't want to continue the pregnancy, and this time I this decision is very firm and I don't want to go back. So she underwent an MTP, and after that, patient again followed up with me, told me that doctor, right now also I feel a guilt about it that I had to terminate, but during my pregnancy, I literally had suicidal thoughts that why am I carrying the baby because of the peer pressure of the society. So this was the case which did let me start made me think started I started thinking, see, IVF conception, we have to always give that the efforts put by the doctors also and the patient also, but somewhere around the down the line, patient women most of the times are taking peer pressure of the society that they have to have a baby, and when they are not able to do so, they land in this disorders, mental health disorders, leading to depression and suicidal thoughts. Here, as a role as a gynecologist, our role is to understand their needs, their mental health status, the family background, and help them immediately wherever they feel that they can talk to you and open to you. Never be judgmental in this. Next. So this was an adjustment disorder that we initially diagnosed for her, which affects 1 in 4 pregnancies. Patient usually presents with persistent worry and fear. Next. Depression usually characterized by low mood, anhedonia, that means loss in interest, mostly over 2 weeks. They do have guilt, hopelessness, sleep fatigue, sleep issues, fatigue. And 12% of the patient usually present during the pregnancy, and that increases 20% to postnatal period. It can lead to self-harm. Sometimes if they deliver and they are going through the depression also, they don't pay good attention to the baby. That's why there is a neonatal flattering growth, and also that is also resulting in delayed milestones. Next. There is certain small variety of the patient do present with obsessive compulsive disorders that is happening in 2 in 100 pregnancies in antenatal period and 2 to 3 in postnatal. Usually we may think that why OCD should cause such a serious problem, but what happens is they when the baby is born, they keep on cleaning the baby excessively. They will clean them, bathe them again and again. They will be worrying throughout, so they don't eat well, and it results in compulsive actions that they take, and that's why sometimes it may be so extreme that they may need admissions. Treatment remains the CBD and medication, cognitive behavioral therapy and medication. Next. These are anxiety disorders which leads to persistent worry and fear. Sometimes the anxiety may be because of previous traumatic experience that they have during their past deliveries. Fear of labor, going through the YouTube and everything, they have already seen how the labor goes and then they fear a lot, and that results in anxiety. Next. Bipolar disorders also, sometimes they are hyperactive, they are having elevated mood, and sometimes this results in mania that can lead to just they are wandering here and there, they are skipping, they're exercising, that also results in risky pattern, and sometimes depression which may lead to suicides. Next. Schizophrenia, as we all are aware about schizophrenia's positive and negative symptoms, sometimes there can be hallucination, delusions, and disorganized thinking. Negative symptoms in particular, wherein they lack attachment towards the baby, emotion or facial expressions, which may result in problems. Next. So this is what we have already been talking about in post-graduation, and we have always, I think those who are working in done residency in BMC, we have at least have one patient of postpartum psychosis wherein we get the call in the middle of the night that the patient is wandering and running in the ward and she's just screaming. So there are these conditions where are called as postpartum blues, postpartum depression, and postpartum psychosis. In postpartum blues, it is usually a self-limiting condition, nothing major, but patient usually remains low mood. She's not talking much, and usually the psychological and hormonal factors are playing the role. And it usually coincides with the milk coming in. That is usually third and fourth day. By the 10th day, patient is usually fine. Only what you need is support with the family and the counseling. Whereas in postpartum depression, it is slightly to be likely to be longer periods, starts within 1 month to 1 year postnatal, and here on we have to be on caring and little bit inquisitive to ask patient what are exactly her symptoms and whether there is any symptom suggestive of self harm or the baby harm, wherein you need to admit the patient. The treatment is usually counseling first, cognitive behavioral therapy, and we can start with SSRIs, that is a sertraline, which is safe in pregnancy as well as in breastfeeding. Whereas in postpartum psychosis, as I told you, the patient wanders here and there, they hear voices, and they are running, they no don't take care of the babies also because the insight is lost. And they, if supposing there is a history of postpartum psychosis in previous pregnancy, 50% chance that they will have the symptoms will recur in the next pregnancy. So history into the psychotic symptoms and mental symptoms is very important. Next. So what are the risk factors whenever we are taking the history? Early pregnancy or advanced maternal age, substance abuse, domestic violences, broken families, family history, sometimes sepsis, personal history or previous mental disorders or previous traumatic deliveries. If we see the red box here, we see that if the woman has a history of bipolar disorder, 25% chance that 1 in 4 chances that she will have the bipolar disorder in this pregnancy. If she has a history of postpartum psychosis, that is 1 is to 2, that is 50% chance that she will have. And with the history of postpartum psychosis, with the personal history of bipolar disease, as well as the family history, mother or sister having, there are 75% of the chance that it will recur in this pregnancy. So you have to be very, very careful when you take the history. Ask history in the mother as well as in the sister. Next. So how do we assess? Take those extra 10 minutes to talk to your patient. There are various score system, scaling system, and questionnaires is available. You can follow any of them. The Woolley question is given by RCOG and NICE. There is something called as GAD, General Anxiety Score, Disorder Score, GAD 3 and GAD 7. And also there are something called as physical health questionnaires. So all these questionnaires, you can take any of any of those sorts, what I have started doing in my OPD is that whenever the patient is sitting in waiting area, I give them these questionnaires and I ask them to tick by themselves, and I just reassess them. I give it in the first trimester as well as in the third trimester and after the delivery once they come for the suture removal. So these questions is, have you felt low mood or feeling down or depressed in last month, or you are feeling that there is no pleasure in whatever activities you used to do earlier? If there is a yes answer to any of the question, it is a positive test and you have to she requires further evaluation. If the answer is no, it is a negative test. That means patient is not depressed. Next. So these are the list of questionnaire that you, an important question is, I can, there is a big list, but I want to tell you the important question. If you feel the harming, do you feel like harming yourself? Do you feel like harming the baby? Also, you have to check the inside by asking her questions like, do you remember who was there during your delivery, how the delivery experience was and everything? And very important, are you breastfeeding your baby? So if she is not breastfeeding her baby and she is not seeing her baby, that means she is going into the major depression if it is a depressive episode, and if she doesn't remember, it is probably a psychosis. So you need to admit such kind of patient and give them care. Next. Next, please. So what are the red flags? Recent significant change in the mental status or any new symptoms, new thought of a thought or act of violent self-harm, new and persistent thought of incompetency or estrangement from the newborn. So this is basically she wants to go away from the newborn. Next. So whenever you see these red flags, you have to address this need and inform the psychologist and psychiatrist, admit the patient, keep the patient in care with the family, friends, and don't let the patient go alone anywhere. Next. So this was the Asian Journal of Psychiatrist, where this was also they addressed the suicidal deaths in pregnancy at Apex Institutes in India, who said that there was a more suicidal deaths occurring in the first and second trimester. Also, the male fetus was also one of the cause risk factor that they had evaluated. Next. Next, please. So these are the key, as we have already known through the slides that we have gone through. So pre-pregnancy, you have to discuss the course in pregnancy, family support. If you know that they are already on any antidepressant or any antipsychotics, you don't have to stop any of those on your own. You have to take the help of psychiatrist. Say switch to the safer medication, keep the dose adjustment, keep the medicine dose lowest. Discuss with them what is the course going to be in the pregnancy, what side effects, what anomalies we expect, and what is going to be after the delivery. Next. Throughout the pregnancy, if it is an accidental pregnancy and you think that she was on certain drugs like lithium or other drugs such as venlafaxine or valproic acid, you have to discuss them the options of the, after discussing with the psychiatrist, the option of medical termination of pregnancy, and if not, they want to go ahead with the pregnancy, take their help and explain everything in details. The certain calls are if you stop the drugs on your own or there is sudden withdrawal, newborn also leads to neonatal adaptation syndrome, so that you have to discuss. With certain antipsychotic medications, there is a risk of GDM, so you have to screen patients for insulin resistance. And if the patient is on lithium, you have to check the levels every month till 36 weeks, during labor also, and every week also. Next. Post-pregnancy breastfeeding, you can continue with the breastfeeding if patient is on olanzapine, quetiapine, or sertraline. But if she's on lithium, carbamazepine, or valproic acid, you need to avoid breastfeeding. Give patient continuous support, do the dose adjustment and counseling. Next. So this is the same thing that I had discussed about the drugs in breastfeeding and pregnancy. What is the safety and what you're supposed to, how you're supposed to monitor the drug levels. Next. So take home message is pregnancy and postpartum gives, and pregnancy and postpartum period is the one which gives the healthcare facilities to they get longer access to the patient. So you have longer time to evaluate, to talk to them, so that you can take out more and more cases. Be non-judgmental and empathetic. Whatever their worries are, you have to address those worries. Don't compare it with anyone else. Just address their needs and tell them that we are with you in this your journey of pregnancy and postpartum period. Thank you. So that was my time. I hope.
Uh, yes, ma'am, Pranita, ma'am, that was a great talk. We have a very different topic. And if anyone has any queries, please put it in the chat box so that we can take them later, or we can reply in the chat box as well, ma'am. Thank you so much.
Thank you.
Um, Swastika, can you share the CV of the next speaker? So our next speaker is Dr. Ankesh Sahitya. Sir is an obstetrician gynecologist at Pushpa Hospital and Brilliance Fertility Center. Sir is also an honorary at Oshiwara Maternity Home. So we welcome you, sir. Over to you, sir.
Yeah, thank you so much, Monica, for introduction. I've shared my presentation. Do I have to share my screen again?
Sir, whatever's comfortable. If you don't want to share, I'll
I
ask
can share.
Fiona to.
I can share my screen. I have no problem.
Okay, sir, no problem.
Yeah, I hope everything is visible. Is my slide visible?
Yes, we can see.
Yes, sir, we can see, sir.
Yeah. So everyone, thank you, AFG and President Nitin Shah, for giving me the opportunity to give this talk on ovarian rejuvenation and the emerging advances in reproductive longevity. I'm Dr. Ankesh Sahitya. So we all know the sad reality of infertility in today's day and age, with late marriages, late childbearing, women in their early 30s, not yet married, not sure of their fertility levels because of their career, not able to get the time to, plan a child, or not having the keen interest in childbearing then. So the declining fertility levels basically are a key driver of female infertility, perimenopause, and novel regenerative approaches aim to restore the levels of fertility and ovarian function using autologous biologics. So what do we do over here? So what are the mechanisms of ovarian aging? So basically there's follicular depletion because of apoptosis that happens with age, oxidative stress, there's a mitochondrial dysfunction, reduced ovarian stem cell activity. How do they reflect in our practice? We see elevated levels of FSH very early, we see low AMH, and we see irregular cycles. So what does the word rejuvenate? Rejuvenate means to make something more effective, modern, successful by using new ideas and methods. So ovarian rejuvenation is a process by which production of eggs is artificially stimulated, giving the woman a chance to produce more eggs than they would naturally have been able to do, and giving them more chance to conceive using their own genetic material. So what is rejuvenation? The process defined as intended to re-awake the egg maturation and development within the ovary by activating dormant follicles. So let's talk a little about the actual biology. So a woman is born with 2 million eggs. That everyone knows this part of science. About 11,000 of them are lost every month prior to puberty. And once she hits puberty, after her first period starts, she only is having around 400,000 eggs. After this, every month the woman continues to lose around 1,000 eggs. Now, by the calculation, you can imagine the amount of eggs she loses will determine at what rate she loses her eggs. And also, irrespective of medicines, OC pills, pregnancy, health issues, a lot of damage already happens to the ovaries. So, over the last 20 years, we are finding rapid decline in the ovarian reserve. More and more women are suffering from poor ovarian reserve at an earlier age. This could be the result of environmental pollution, toxic substances or fertilizers, or in our food, maybe the situation, the stress we live in. Whatever may be the reason, the fact remains fertility levels are rapidly going down. So, what are the indications for the entire topic of ovarian rejuvenation? Anyone having early menopause or perimenopause, infertile women, women over the age of 35 years having low egg reserve or low AMH levels, women under 35 years of age with low egg reserve and low AMH levels, premature ovarian failure, POI, loss of ovarian function due to cancer, chemotherapy, and ovarian dysfunction. So, what are the three mechanisms by which we actually work on ovarian rejuvenation? The first one, which I'm going to talk about in detail, is PRP or platelet-rich plasma. So, they basically get growth factors from the platelet-rich plasma, which stimulate local stem cells and angiogenesis. This is the more indirect way. The more direct way is the mesenchymal cells, the stem cells promote folliculogenesis and endocrine activity. Then we have exosomes and peptides, targeted signaling to enhance ovarian niche regeneration. And we have DHA and other supplements which help in also helping the ovaries to have a little more rejuvenation. So to begin with, the first application of the ovarian platelet-rich plasma was done by Pantos et al. In very recent 2016. They reported a temporary dissolution of ovarian activity in perimenopausal women after autologous PRP treatment. This involved injecting PRP directly into the ovaries to potentially trigger a resumption of menstrual cycles in women experiencing signs of menopause. PRP classification. After centrifugation of the whole blood, four preparations can be obtained. These can be classified depending on their cell content and fibrin density. The theory behind the modality is very simple. It's basically the body's first response. Whenever anyone has any injury, any cut or wound, the platelets go to the injured site first. The platelets promote healing, attract stem cells, and clear to the site of the injury. PRP. So, what are the four principles of PRP preparation? Harvest, separate, activate, and return. Let's study this in super detail. So PRP is extracted using only a centrifuge machine with a special conical tube. You can't use a normal curved test tube. You have to have a conical tube. At least 15 to 40 ml of blood is taken from the patient autologously, injected into the conical tube at 21 to 24 degrees, and this is spun at 12,000 RPM for 12 minutes. Now, when we do a PRP, anyone who's worked in the lab knows there's an upper, middle, and a lower layer. The upper layer, which is the layer which is containing platelets and WBC, the middle layer is only WBCs, which is called as the buffy coat. The lower is always the RBCs. So what is the preparation we see? So as you can see, this is the entire tube containing the venous blood. And after the centrifugation, this is the upper, middle buffy and the lower red cells over here. The upper layer is the platelet-rich plasma. As you can see, this is the conical tube. So this is the procedure how we do the PRP. As you can see, one sec, I'm not able to press play. So this is a laparoscopic procedure run at our center. We have injected a 17 gauge needle through a 5 millimeter port into the cortex of the ovary. You can look at the beautiful video how the beveled edge of the entire needle is entering the cortex of the ovary. After mild aspiration, we inject the PRP fluid into the cortex of the ovary. This is exactly how we do it after preparing the PRP. Around a month to at least 45 days after the procedure, we advise the patient to do a FSH on day 2 or an AMH directly along with an E2. This gives us the values of comparison before and after. I personally don't do more than 2 or 3 pricks in each ovary, depending on the ovarian volume, size, and the skill of the surgeon. Oh, sorry. Yeah, so this is the proposed mechanism of how the ovarian function is applicated. So the minute we inject anything to do with PRP, we have to think of chemokines and the mitogenic growth factors. So interleukins, IGF, VEGF, all these things, basically these are what stimulate the ovarian stem cells, and this leads to differentiation forming oocytes. So PRP is an innovative therapeutic modality, affordable. It is even simple to carry out. It is simple to prepare. So intraovarian PMP, it would still be called as an experimental in majority studies as for diminished ovarian reserve, poor ovarian response, and POF. There is a need for more research on the cell and molecular level. They require more standardization of preparations of PRP, more RCTs, well designed, and that's how we'll get more comprehend with the whole thing. So, what are the follow-ups? The follow-ups after doing a procedure are definitely doing an AMH. So, you basically when you do this procedure, you have a pre pre PRP AMH and you have a post PRP AMH. There should be at least a gap of around, I would say, 45 days. Some doctors even take it as 2 months. Some doctors take it as 3 months. I would say you could start with 45 days between doing an FSH from the procedure till after the 45 days. You can do a day 2 FSH, LH, E2 levels at monthly intervals in women who do not menstruate during the menstrual flow in the menstrual movement period of 6 months. If the AMH levels rise while the FSH and LH levels become lower, this is an indicator that the PRP has worked and rejuvenation is demonstrated. So coming to the next part of the lecture is stem cells. The first part was only platelet-rich plasma. Now we go a notch earlier, which is the stem cell therapy. So the first reported procedure was done by Dr. Yan et al. And his colleagues very recently in the lockdown of 2020 in the Journal of OBGYN. They injected cells into the woman with primary ovarian insufficiency to potentially rejuvenate the ovaries. So the mesenchymal cells promote follicular genesis, endocrine activity, stem cell therapy can potentially reverse the diminished ovarian endocrine function and restore fertility. Beyond direct POI therapy, stem cells show promise in supplementary applications such as ovarian tissue cryopreservation and tissue engineering. So this is a very beautiful slide on how actually the pluripotency of the mesenchymal cells is demonstrated. So you can get these stem cells at childbirth from the umbilical cord, the placenta, the amniotic fluid, the skin, and the adipose tissue. What are all these stems called? These are called stem cells or the mesenchymal cells. These are totipotent or pluripotent where they can be differentiated into bone, muscle, cartilage, fat, endothelium, and even epithelium of the skin. So the potential of stem cells is not hidden from anybody. It has been used in various fields of science for various forms of cell differentiation. So, going over the entire procedure, since this is a stem cell procedure, we require stem cells from an adult patient. The best site for getting the stem cells is from the iliac crest of the bone marrow aspiration. This is a procedure done under mild sedation or local anesthesia. You can even go for pre-medication for angiolysis. After anesthesia, the patient is given prone or I prefer lateral decubitus. In the cases I do at my center, the patients are always given lateral decubitus with hip flexion for iliac crest axis. So this is basically because of the coordination and of me and Dr. Patil, who's my hematologist. We do our cases together usually. So we use lidocaine or 2% or 1 or 2%, which is injected subcutaneously using a 25G needle. Now a 22 gauge needle is injected deep into the periosteum and also 510 ml along the needle tract and the periosteum. So as you can see, it's a beautiful 22 gauge needle which is entering the spongy bone. Now remember, the bone has two layers, the cortical bone and the spongy bone. The spongy bone is what contains the marrow. So once you enter the marrow and you get a free resistance, you get aspiration of bone marrow. This is like liquid gold. You get this kind of marrow. It's a very, very important thing because the stem cells are intact over here. So the preparation is simple. As you get the marrow, the preparation happens in the lab. I won't go into the lab details, but the injection site into the ovary is just like how I showed it in the previous video of the stem cells. So, what are the clinical applications with premature with in this ovarian rejuvenation? So again, it's again a top contender for POI, premature ovarian insufficiency, poor ovarian response in patients above 35 who have low AMH, who don't want to go for donor egg, who want to have the last resort. They don't want to go for donor egg. They are very keen that their own eggs are used despite a low AMH. This is there. So we get patients also have early menopause and perimenopause. They don't want to undergo the transition. They want to get regular cycles. There are patients who come and ask us for all these things. So low AMH and high FSH is the benchmark of the reports. So you can't label a case as POI or POR unless you have a low AMH and high FSH because this is pathognomic and biochemical perimenopause or menopause. So what are the considerations of clinical use? You have to have standardization of protocols. Patient selection is critical. You cannot do this for just anybody. Like I mentioned in the previous slide, you have to have a patient who has POR or POI with low AMH and high FSH. Ethical and regulatory aspects in evolving landscape. Future directions, larger RCTs needed for validation, potential integration with AI-based fertility prediction and personalized therapy. So what are the clinical evidences? We have PRP studies. We have a lot of meta-analysis in the Journal of Reproductive Assisted Genetics in 2023, which also predict a rate of 30 to 40% ovulation in POI cases after PRP injections. This rate improves to 50% for POI after mesenchymal or stem cell infusion. Also, this is used in ovarian cryopreservation and reimplantation cases. Of course, there are multiple challenges. There's lack of standardization. Protocols vary widely. There are ethical concerns. How people get these stem cells? Are they embryonic or adult? The cost, the accessibility. Experimental therapy is often out of the pocket. Safety, long-term data, and also cancer risk because of stem cells is also a known risk. So, ovarian rejuvenation is a rapidly evolving field, potential but remains experimental. PRP and stem cells show promise, but as I mentioned, rigorous RCTs are needed. We are still long away from making this as a standardized treatment. This is still going to be called as an experimental treatment till there are set guidelines by the government and the national bodies. Ethical and regulatory frameworks must evolve alongside science. So, of course, there are so many lovely papers. There's a lovely paper by Pantos et al. Pantos was the person who did the first case of ovarian PRP in 2016. This is his study. His results showed successful rejuvenation by 1 to 3 months after ovarian PRP. So almost he saw 2.5 to 3 follicles of 15 to 70 millimeter diameter after 3 months. This is a very good result. You can see it in the results section. This paper is available online. Also, there's a beautiful CRM review article by Aishman Snehadatha Dawood on the same thing on how platelet plasma is being used for various things for ovarian rejuvenation, for endometrial rejuvenation. We've done the same case at our center with uh, subendometrial PRP and also done it with ovarian rejuvenation. So, of course, the conclusion our data shows for the first time there's successfully temporary activation. So, I would say the best time to know you're successful is 1 to 3 months post procedure. If you do the test after 3 months, you might not be so impressed with yourself. After verification, our results in larger population groups. But of course, as I mentioned, is a long way away for doing for being confirmed. There are a lot of RCTs required. Till then, it's going to be called experimental. Of course, nothing is without side effects in our line. So of course, they are very minimum. In the 10 cases I have done individually, I have not seen them, but of course, there could be pain at the bone side. Where you aspirate from the iliac crest, there could be severe pain over there. There could be fever and internal bleeding, but it's not seen usually in good hands. There are other techniques also used in doctors who don't want to do ovarian PRP and laparoscopy. There is hormone-based modulation with DHA, growth hormone. There is a CRISPR gene editing technique which is happening big time in Sweden and Belgium. There are epigenetic drugs for follicle activation. We are using resveratrol and NAD plus even at our center for certain patients. We also use coenzyme Q10 for mitochondrial repair, mitochondrial transfers, ovarian fragmentation, exosomes coming up in a big way for vaginal laser tightening, also for ovarian rejuvenation, and also ovarian tissue cryopreservation in patients undergoing any form of cancer chemotherapy and want to preserve their fertility. So, what is the future? Apart from rejuvenation, researchers are going to oocyte vitrification, where you rapidly slow the aging process of the eggs. This means that a woman may put off trying for a baby for longer without fear of decreased fertility. This is also a great option for women who need to undergo treatments for cancer, who have the chance to preserve their fertility. Again, as we always say, preserving oocytes is the best form to preserve fertility. In conclusion, ovarian PRP and stem cell treatments, while promising, are still considered investigational therapies. Statistical reviews and studies from studies show that some improvements in ovarian reserve parameters and potentials for increased pregnancy rates, particularly in women with diminished ovarian reserve. But as I've mentioned multiple times in my presentation, larger RCTs are needed for conclusive evidence. So, what are the results for ovarian PRP? You have improved markers. Primarily, what we will do as gynecologists for our patients is AMH, FSH, and E2. As embryologists, as infertility people, you will definitely notice a higher number of M tools, which is a mature eggs, increased pregnancy rates. That is the what we want. Also, in patients who are doing natural spontaneous pregnancies, the rate improves and with IVF outcomes. So, what are the results of ovarian stem cell therapy? Stem cell therapy like PRP may also improve ovarian reserve markers for AFC, potential regeneration. Stem cells can diffuse into healthy ovarian cells, leading to regeneration of ovarian tissue. Also, one source is there which claims success rate of 67% or higher in patients with diminished ovarian reserve with their therapy. So, important considerations we have to remember before we end this presentation. This is still an experimental status. There is need for larger trials and there is individual variability. It differs from patient to patient. Both PRP and stem cells for generation are considered experimental and not widely accepted. Need for larger trials, more randomized control trials are needed. Individual variability response to treatment can significantly vary. While PRP and stem cell therapies are overrated, show promising results in some studies, more research is needed to establish their effectiveness and safety for routine clinical use. Thank you so much, everybody. Any questions? I can take them now or later on the chat box.
So,
Thank you,
since
sir.
till yet we didn't receive any question, if we receive any questions, I will be noting them down in the chat box.
Thank you, sir. That was a great talk, sir. It was both informative and quite engaging.
Thank you, Monica.
Thank you. Thank you, sir.
Sir, please stop sharing your screen.
So our next speaker for today is Dr. Rashida Garg She's a advanced endoscopic gynecologist surgeon, freelancing as well. Apart from that, an obstetrician and gynecologist at Adarsh, Malad West, Garg Multispecialty, Malad West, Ashoka, and Harihant Hospital. Um, Thank you, we'll ask Rashika to start her presentation.
Hi, thanks for the introduction, Monica. So can I share my screen? Yeah. Okay. You can see, everybody can see this?
Yes, yes, just started. Yeah.
Okay. Okay. So hi everybody, I will be talking about the metrics of endometriosis, basically the surgical management of endometriosis. So we all know what endometriosis is, the presence of endometrium, which is the endometrial tissue or stroma outside the uterus, associated with an inflammatory process, affects up to 10% of reproductive age women. It is a chronic, benign, hormone dependent and a systemic condition. So as you can see, the burden of this disease is, it's quite severe. So we have to manage it accordingly. So the clinical profile can vary. The patients may present with pain, which can be chronic pelvic pain, dysmenorrhea, constipation-related pain, severe dyspareunia as well. Many of the infertility patients present to us with this presentation of endometriosis, and many of them are asymptomatic, and they come for infertility treatment, and then when you do a diagnostic scopy, that is when you find endometriosis. It's quite common. So like everybody knows this, so diagnosis of endometriosis is very challenging because honestly there is no exact mechanism which can help you confirm the diagnosis. So an examination of a patient suspected with endometriosis is must, because it can help you detect any nodules, any rectovaginal nodules, and also any you can assess the mobility of the uterus, any adnexal mass, so that can give you a clue. And also you can refer the patient for an ultrasound or an MRI, but only great sonologists can detect the minor, smaller endometriotic lesions, but they may also be missed. So you have to keep in mind that even if your imaging does not show you all these lesions, that does not mean that endometriosis is ruled out. In a patient suspected, you have to go ahead with a diagnostic scopy, because that is the gold standard for confirming a diagnosis. So the other benefit of doing a laparoscopy in endometriosis is that you can provide the therapy, that is the pain relief, give improved fertility outcomes to the patient. And but you have to keep in mind that the recurrence is almost 40 to 50%. So in 5 years, which is quite a lot. So you have to offer a multimodal approach, surgery along with medical management, not neither of them alone. So what are the ASHI recommendations regarding this? Is yes, it does say that both diagnostic laparoscopy and imaging combined with empirical treatment, so either of them can be considered. And in case of a surgery, laparoscopy is the way to go. There is no question about this. It does recommend to offer surgery as one of the options to reduce the pain, and also it improves the fertility outcomes in infertility patients as well. But endometriosis can be quite a difficult surgery, and there are many challenges which a surgeon can face. So it is, starting from identifying the anatomy, the variable appearance of the endometriotic lesions, the risk of damage to the visceral organs, and the recurrence of this. So what are the different lesions? Because it is important to identify all the different lesions, because identifying them helps you to treat them and helps you to remove them, and then helps you to prevent recurrence and give better outcome to the patient. So they can appear as red lesions, which basically indicate active implants, which are highly vascular. Once the hemoglobin gets converted to hemosiderin, they form these dark black bluish powder gun appearance. Then over a period of years, when they are present, they can form all these white puckering fibrotic lesions, which is generally encased around vital structures like the ureter, and even formation of nodules, which can be associated with this. There are also these lesions called as the blebs. So basically they are clear vesicles, and they might be easily missed because they are clear, transparent, small in size, abundantly present, especially over the peritoneum and the uterus as well. You have to note that in majority of the patients, you're going to see a mixed pattern. You're not going to see only one finding in either of the patient. So you have to mark all your lesions, and then you have to go ahead with them. So the different sites where your endometriosis can be present, the peritoneum is the most common site, the visceral peritoneum that is, and the lesions can present in all different types as described before, and they can be either superficial or deep. So superficial is generally when it is less than 5 millimeters in depth. And then the ovarian endometriosis can again be from superficial to deep, where superficial it can be just some blebs or certain dark blue spots, or it can even lead to large endometrioma formations, which may up to be up to 6-7 centimeters as well. And then the deep infiltrating endometriosis is what causes the major burden of this disease. So they are generally more than 5 millimeter in depth, and they cause nodules and fibrotic lesions which encase around the bowel, the rectovaginal septum, the ureter, and they contribute to a lot of pain and organ dysfunction as well. The adenomyosis is also related to this. It's basically the presence of the endometrial tissue inside the myometrium, and the focal adenomyoma may be considered for excision depending on the patient profile. So it is important to grade the endometriosis. The most commonly used classification is the revised American Society of Reproductive Medicine classification, where we have 4 grades. So first is the minimal endometriosis, which is just few superficial implants. In mild, you have more deeper implants, maybe some mild adhesions. In moderate, there are deeper implants, smaller endometriomas are present. And in severe, generally, it is large endometriomas, dense adhesions, causing complete obliteration of the pouch of Douglas. So before starting any surgery or posting any patient with endometriosis, you have to take a complete consent from the patient. So you have to discuss all the possible recurrence rates, the risk of the organ injury. You have to be very open and honest with the patient. Yes, it is difficult, but it is more difficult to tell the patient in the post-operative period, yeah, that something has happened. And you cannot just leave a surgery incomplete. You have to perform a complete surgery for better outcomes. So it's better to talk through the patient and, discuss all the possible options, what she's willing for, and accordingly plan the surgery. You also have to tell her about the possible risk of stoma creation in case of any bowel injury, and the impact on fertility that there may be in case of large endometriomas, especially ovarian endometriosis, where energy sources are used on the ovaries. And it's always a good idea to get a preoperative AMH level done, because these patients already come with a poor AMH. So it just keeps the patient informed as well as it keeps you medico-legally safe. And you have to tell the patient that there might be a small risk of reoperation in case of any recurrence, or even the risk of any complications, you might have to reoperate this patient. So in order to reduce these complications, it is always better to have a standardization of operative steps. In fact, for any surgery, your steps should be standardized. So it begins right from when the patient is on the operative table. You are giving the position to the patient, and then you have to tell your anesthetist that, okay, you can give tranexamic acid, because that helps reduce the bleeding. So that is what we generally use. Then the next comes is the port placement. So port, again, these patients are previously operated, so they might have dense adhesions. So you have to consider higher supraumbilical incision or a palmar port entry, or even use a VisiPort as well. These can help prevent any direct trocar injuries to the bowel or any various needle injury to the bowel as well. Then the first step, once you're in, is to scan the abdomen, including the upper abdomen scan, because you have to correlate with any other findings which may be present. Sometimes you might get a fatty liver, or you might get some pelvic inflammatory disease which may coexist with endometriosis. Then you come to the pelvis, look at the anatomy in detail, give the patient head low, evaluate the entire pelvic structures. So you look at all the 3 compartments, the anterior, middle, and posterior. Especially look under the ovaries, look at the ovarian fossa. So this is basic in any even diagnostic hysterolaparoscopy for any infertility patient. You have to go lift the ovaries up, look below, see for any endometriotic lesions, and look at the pouch of Douglas and scan the entire peritoneum. Once you have identified, okay, what are your lesions, what is your anatomy, what we generally prefer to do is we use the vasopressin injection in the retroperitoneum as well as in the pouch of Douglas, because that helps in reducing the bleeding during our dissection. Then the first step of the core surgery is the retroperitoneal dissection. So we prefer to do this before we start with anything else, because as we prolong the surgery, the carbon dioxide, basically it causes carbonization of the retroperitoneum. So it causes it to become opaque. and then identifying the ureter through it, and doing a clean dissection of the retroperitoneum becomes a little bit more challenging. So always just do it first. Open up the retroperitoneum, identify the major vessels, identify the ureter, the course of the ureter. Just right from the pelvic brim, especially in deep endometriosis, go from the pelvic brim up to the insertion of the uterosicles. Just bear out the ureters on both sides. Then the next step is to restore the anatomy, perform adhesiolysis, understand what is, intense dense endometriosis. You might, in grade 4 endometriosis, you will not be able to understand, where your tube is, because it is distorted, where your ovaries are, which side is what, the cyst is coming from the right side, the left side, where is the rectum ending, where is the, where is the ovarian cyst. So you have to perform adhesiolysis with great caution and care, restore your anatomy before going ahead with the excision of all the endometriotic lesions. With the excision, you have to keep in mind to perform a nerve sparing surgery, since you have to preserve your inferior hypogastric plexus, which runs medial to your uterosicles. So you do not want your patient to have dysfunction in bowel and bladder capacity. So you have to ensure that your excision is a nerve sparing surgery. Any superficial endometriotic lesions, you can consider fulguration of those lesions. Then the specimen retrieval has to be inside a bag to prevent any port site endometriosis. And you send that tissue for histopathological reporting, confirm your hemostasis, and close all your ports. So any port more than 7 millimeters infraumbilically and more than 1 centimeter supraumbilically has to be closed. So just showing a few videos. So this is a video of a narrow band imaging where basically different frequency of lights are used. And this helps in identifying the endometriotic lesions, as it shows lesions with higher vascularity very nicely. So all those dark spots which you can see, those are all endometriotic lesions. So these, it's really helpful. It's generally present in the Karl stores and in the Olympus system. You have the spectra mode in the stores. Again, in the stores, you have the advantage of having a directly camera controlled, where you can, use the camera head and control the different modes which you're using. So all these videos have been taken up by Dr. Prashant Bhamre sir, who is my mentor. And sir has been wonderful and kind enough to provide me with all his videos. And Dr. Mrinalini has helped me edit all these videos as well. So here we can see the peritoneal endometriosis, the excision of it. So you have to identify the ureter, tent up the peritoneum, and then go along parallel to the ureter, lift up the peritoneum nicely, identify the ureter, be away from the vital structure. So you can see there are two prongs to the ultrasonic shearer that we're using here. One is the active blade and the other is the passive blade. So the passive blade does not conduct any current. So it is only the active blade. So that the active blade is a black one. So that we have to keep away from the vital structure, which is in this case the ureter. So you identify, you can see the ureter running below, minding its own business. So you let it be, push it away. And all this disease peritoneum you have to remove. So it is very important to know all your spaces, important to know your anatomy in detail, because without that you cannot proceed with the surgery, and you cannot proceed with any surgery for that matter. So with the help of cold scissors or harmonic, you can use this. The advantage of using ultrasonic shear is that there is minimal lateral thermal spread, so to the vital organs as well. So this is the excision of an ovarian endometrioma. First you take an incision on the antihylar surface, you drain the cyst, and then you excise the cyst wall from the normal ovarian tissue, keeping in mind to use minimal current on the ovarian surface. But you have to keep in mind that the endometriotic cyst does not behave like a normal ovarian cyst. So it is not possible to remove it intact, and there are going to be adhesions between the cyst wall and the normal ovarian tissue. So you have to use any cutting device in order to separate that as well. Again, identifying the normal tissue versus the abnormal cyst wall becomes challenging. And the tissues guide you by identifying the correct plane of dissection and separation as well. So the key is to use minimal energy sources on the ovary to preserve the ovarian function. This is the excision of a rectal endometriotic nodule. So here you have to keep in mind that this is a very you have to be very careful of not injuring the bowel. So you can use a vaginal bougie to in the posterior fornix to lift up the pouch of Douglas, and then it helps to give you a good amount of support and traction, and you can easily identify the rectal nodule, and then you can separate it. Always cut on the action of the uterus so as to prevent any injury to the bowel. When you're doing any peritoneal endometriosis, also you have to keep in mind to identify the uterosicles and not go medial to the uterosicles to prevent any nerve injuries. Okay, so here this is a video of a ureteric nodule excision. So you can see the ureter is, it's completely encased, the ureter, and you have to be very careful while dealing with such a case, keeping the active prong away, using the passive prong as a support. Thankfully, the ultrasonic shear is a very good device, very, very minimal lateral thermal spread, almost no lateral thermal spread. You cannot do this with a cutter, it's very challenging, very difficult, it's very risky as well. So complete excision is important because this can progress and lead to ureteric obstruction as well, leading to hydronephrosis, hydroureter. So you have to excise all these lesions. It also helps relieve all the pain with endometriosis. Then the adenomyoma excision can also be considered, again depending on the patient's age, fertility, desire. You can discuss all the options with the patient, tell her about the pros and cons, and then you can go ahead with the excision of an adenomyoma. So as you can see, if you've ever done a myomectomy, in myomectomy, you can easily identify the fibroid tissue versus a normal myometrium. It's not the case in an adenomyoma since it's all diffuse. So it's and the suturing of an adenomyoma is another challenging process. So what is the summary of the surgical approach? So one is that excision instead of ablation. You can ablate, that is fulgurate all the superficial lesions, but all the deep lesions have to be excised. Always do a cystectomy, never just drainage and coagulation. That is not going to give you good results. The endometriosis is just going to recur. Then specific caution has to be used to minimize the ovarian damage. Use bipolar only when necessary and only on lower settings to cause for hemostasis purposes. Keep your vital structures under vision, bowel, ureter, wherever you're cutting. You just be very careful. And everything, remember, in laparoscopy, it has to be under vision. Whatever your cutting instrument is, has to be under vision. Use intraop adjuncts like Tranexam and vasopressin. And after the surgery, yes, you have to provide with a good detailed operative notes. So you have to completely document the entire surgery, the mapping, the compartments involved, the extent, the adhesions, and to what extent, what exact surgical steps were followed, what was excised, what was ablated, any nerve preservation techniques that were used, and what was the staging as per a standardized staging method. And then document the use of energy sources, whatever was used in the surgery. In the post-operative care, two things are of vital importance here. One is the down regulation. Second is the fertility plan of the patient. So what does ESHRE recommend is that it does not recommend to use pre-operative hormone treatment. So no pre-operative hormone treatment. Okay, but post-operative hormone treatment is a must to cause down regulation, especially in patients who are suffering from pain because of endometriosis, and also to prevent recurrence. But this is only in patients who are not desiring immediate fertility. In patients who want immediate fertility, please go ahead and consider an IUI with an ovarian stimulation, or in patients multiple risk factors, go ahead with ART. Do not do down regulation. Just go ahead with the fertility management of this patient. So the take home messages are: one is endometriosis is diverse. So identify all your lesions, recognizing them is vital. Standardization matters to prevent and minimize complications, also ease your surgery as well. Recurrence is common. Counseling of the patient is important. Again, counseling of the patient that the stage and severe symptom severity do not coexist, because you have to tell her pre-operatively and post-operatively again about the extent of a disease, and it may or may not correlate with the symptom severity. So let's keep moving towards a precision surgery, a patient-centered care, and a collaborative research to improve the outcomes of women with endometriosis. Thank you.
Thank you, Rashika. That was a very excellent presentation, quite informative as well, and great videos also.
Thank you, Monica.
Our next speaker for today is Dr. Shweta Mishra. She is the co-founder and chief gynecologist and infertility specialist at Liberty Healthcare IVF Center, Malad. Also has been a consultant at Niron, also the consultant at Niron Hospital, Kalina, Santa Cruz. Santa Cruz. Dr. Shweta, you can start your presentation. Dr. Shweta, you'll have to unmute.
Okay, am I audible now?
Yes.
Yeah, thank you so much for letting me present a little earlier. Should I share my screen or it will be done?
No, ma'am, share your screen.
One second. I'm not able to share. Can you please do it on my behalf?
Swastika, could you share her screen,
Yes,
please?
ma'am. Yes, sir. Yes, I am sharing. Ma'am, just confirm me that this is a particular PPT.
Yeah, that's correct.
And ma'am, please command me with next whenever I have to move to the next slide.
Sure. Okay. Thank you. Good evening, everyone. I am Dr. Shweta Mishra. So today I will be speaking on triggers in IVF and ICSI. Can you please start the first slide? So as we are all aware of how important the timing of trigger is in the part of an IVF.
मेरा एक webinar था ये मेरा एक online webinar था वो अभी खत्म हुआ 5 मिनट में
Sir, can you please unmute? Can you
मुझे
please
एक तो
mute
फोन
yourself?
आया था विकास भाई बेटा
I think Ankesh, could you please unmute yourself? Unmute yourself, sorry.
Ankesh need to mute Ankesh.
Otherwise,
Or
Swastika
admin can
can.
mute Ankesh. Admin please mute Ankesh. I'll call Ankesh. I'll call
Yeah,
Ankesh.
I think someone.
I'll call. I'll call.
Hello.
If ClearNet people can mute Ankesh as an
Yes,
admin.
yes. I'm doing.
Yeah,
Yes,
please.
done.
Yeah, okay. Go
It's
ahead.
done. It's done.
Okay. Okay, thank you. So as you are aware of that how important the timing of trigger is for an successful IVF cycle. So trigger timing is usually tailored to retrieve a high proportion of mature and competent oocyte from the available cohort. Next, please. Next, yeah. So I would be discussing mainly on when to end the follicular phase, the ideal trigger, and the optimal time of oocyte retrieval, like how long the stimulation phase would be. Next. So usually the interval for a dominant follicle selection to ovulation is usually longer in a natural cycle as compared to a stimulated cycle. So from selection of a dominant follicle to an ovulation, it usually takes around 7 days in a natural cycle. And whereas in a controlled ovarian stimulation, it's around 5 to 6 days. So that is why the ovulation usually happens at around day 16, day 17, if you notice in a natural cycle. Whereas if you're doing a normal antag cycle in an IVF, usually the cycle we usually terminate after 10 to 12 days of injections. So the rate of follicular growth also is different. In an IVF cycle, it is usually 1.7 mm per day. And in a natural cycle, it grows by 1.4 mm per day. What is term oocyte maturation? Term oocyte maturation, basically, it is the minimal essential time to reach the oocyte development competence. So in a normal the ideal duration ideally should in an IVF cycle, that is a controlled ovarian stimulation, should be 10 to 12 days. But this is what I'm talking about, antag cycle. Next, please. So stimulation phase usually, if it is more than 13 days, it is associated with reduced pregnancy, clinical pregnancy rate, and we all must have observed this. So what is the importance of the size of the follicle? Whenever we aspirate from an oocyte retrieval, we usually aspirate the cumulus oocyte complex. So from a large follicle, it is said that the HCG trigger, it promotes secretion of hyaluronidase and it dissociates better from a large follicle. So that is why we tend to get a good COCs from a large follicle which measures more than 18 mm. Whereas if you aspirate from 14 to 13 mm follicle, usually the COCs will be small and the resulting oocyte will also be immature. Next, please. So the cutoff for obtaining M2, what is M2? M2 is basically the mature oocytes. We all know it is divided into germinal vesicle, M1 and M2. M2 is what our target is in obtaining in a control ovarian stimulation. So cutoff for obtaining M2 is 16 mm in one review, but usually we tend to aspirate all the follicles about 12 mm. Below 12 mm, it is very unlikely that a follicle will be containing any mature oocyte, and about 22 mm, usually the oocyte quality is not that great, it is post-mature. This I'm talking about antag cycle. So according to HRA 2020, follicle in the range of 16 to 23 mm usually have a very high fertilization rate than the follicle which are measuring more than 23 mm. So, and we are all aware of that not all follicle will give us an egg. No matter how much we aspirate, all follicles will not be containing an egg. Next, please. So usually whenever we give a trigger, obviously the best method is to monitor by ultrasound, and it is the gold standard and everyone is using that only. Most of our colleagues are using hormonal level as a complementary to ultrasound, but it cannot replace an ultrasound. Serum estradiol or estradiol FSH ratio as a sole parameter for timing of trigger should not be used in ICSI. Your sole parameter only should be your ultrasound finding. And I personally don't use much of estradiol or any hormone level whenever I'm doing a control ovarian stimulation. Next, please. So now there are the two most common protocol that we are using in a IVF cycle is one is a long protocol and one is an antag protocol. The most common one is obviously the antag protocol, which has almost completely replaced the long protocol now at most of the center because of the good compliance. So, but what is the main difference between both of them? In long protocol, you get a better pituitary suppression because we are starting it in a prior cycle in the luteal phase itself. Whereas in antag cycle, the complete pituitary desensitization is not there. Because of which long protocol has a better homogeneous cohort, all the follicles will be more or less of the same size, and we'll get a little better result as compared to the antag protocol. Prolongation of stimulation has a better outcome in case of long protocol. Delaying the HCG trigger by 1 or 2 days as compared to antag protocol always gives us better results in long protocol. Follicle maturation is also attained a little later. So what I mean to say is, whenever we are going up for a long protocol, the trigger should usually be given after 20 mm. Whereas in antag protocol, it is more time bound. The trigger has to be given whenever the follicle reaches 18 to 19 mm. Once the 20 to 23 mm cutoff has been reached in antag protocol, there are very high chances that we don't get that good of M2s. Next, please. So next, type of triggers. The most commonly used trigger we know, one is GnRH agonist trigger and one is HCG trigger. These are the trigger which we are using. So first, let's discuss about the GnRH agonist trigger, which is a more common one. So GnRH agonist trigger, it is more close to a natural trigger. It causes endogenous FSH and LH surge. It is more physiological. It causes a better oocyte maturation. It has a faster onset and a shorter action as compared to HCG. The rise in LH begins at in 1 to 2 hours rather, not even 4 hours. And the LH rise usually lasts only for around 24 to 36 hours. Next, please. And that is also one of the reason why it causes a luteal phase defect, because the LH drops immediately after 48 hours. So this also has a benefit that in case of PCO, there will be a decreased risk of OHSs because it decreases VEGF, and the OHSs risk will not be there. So because of the rapid luteolysis, we don't prefer it if we are going ahead with the fresh transfer. So usually, if you're planning a fresh transfer and if you're planning to give a GnRH agonist trigger, it's always better to do a blood serum LH level 12 hours after the trigger. So the cutoff of LH is 50. If it is more than 50, usually the outcomes are better in a fresh embryo transfer. However, if it is less than it, you might consider giving a good luteal phase support, or rather switching to a frozen embryo transfer. LH should at least be more than 15 international unit per liter after 12 hours of trigger to prevent empty follicular syndrome. Next, please. So, if we are using GnRH agonist trigger and going ahead with a fresh cycle, luteal phase support has to be given. There are two approaches. One is the American approach and one is the European approach. American approach is which is something which we are commonly using. It involves giving 50 mg intramuscular progesterone daily along with estradiol after OPU till 10 weeks of pregnancy. Monitoring also has to be done. One monitoring has to be done on the day of ET. Progesterone monitoring 1 week after the ET and 2 weeks after the ET. Serum estradiol before the ET should at least be more than 200 and serum progesterone should be 20 nanogram per ml. Whereas in the European approach, there is a single HCG trigger which is given 1500 international unit HCG trigger can be given 12 hours post GnRH agonist trigger. And there is another approach where a HCG trigger is given 35 hours after GnRH agonist trigger, which is around the time of pickup. So that has been shown to give a better pregnancy rate. Next, please. Now let's talk about the HCG trigger. So it has been a pioneer in oocyte maturation, luteinization of granulosa cell, resumption of meiosis, and corpus luteal maintenance. It acts on the same receptor as LH because of the structural resemblance. The main difference is only the half-life, which is 60 minutes for a normal LH hormone, and it is 24 hours of HCG, which actually is the main culprit for OHSS, but it has an advantage of providing a good corpus luteal support also. Next, please. So we all know we can either use urinary HCG or recombinant HCG. So the dose of urinary HCG, which is more commonly used, is 5,000 international unit. It is the minimal effective dose which should be used for if you are planning to give a trigger. The yield of oocyte does not increase by increasing the dose. It has been found that dose less than 2000 tend to decrease the oocyte yield, and I don't really think anybody is giving a dose less than that. Next, please. So the difference mainly between the recombinant and the urinary HCG is the purity. Recombinant HCG is a more purer form, and recombinant HCG has an advantage of better dose precision. There is a less batch-to-batch variability, contamination free is there, and a good tolerance is there. So the dose is usually 250 microgram, and it is equivalent to 6500 urinary HCG levels. Next, please. So Driscoll et al. In phase 3 double-blinded study found no difference in number of oocyte retrieved more than and number of mature oocyte and number of cleaved embryos. Even either you use urinary HCG or use recombinant HCG, the result mostly are the same. Next, please. Recombinant LH, this is something which we don't use very commonly because it's extremely expensive. The dose is ranges from 5,000 to 30,000 international units subcutaneously. Next, please. The only advantage is it causes a better, it prevents an OHSS. Kisspeptin, it is more or less in research purpose. They are recently discovered. They signal directly the GnRH neuron, leading to release of GnRH in portal circulation, causing FSH and LH rise from the anterior pituitary. The dose is a single bolus of 12.9 mmol per kg. Next, please. So the trigger OPU interval. So we are all aware of that the trigger OPU interval most commonly it is either from 34 to 36 hours. So the trigger interval is if you see in the table in long agonist protocol, the trigger interval should be a little longer, like as compared to the anti protocol. If I'm doing a long protocol, I usually do a pickup only after 36 hours. It gives much better results and there is no problem at all. If you're doing a long protocol, you should not be doing a pickup before 36 hours. Whereas in ANTAC protocol, 35 to 36 hours is the best interval. Short agonist protocol, a little more earlier because it's close to the natural stimulation. 34 to 35 hours is the interval. And mild stimulation protocol, it's even earlier, it's 32 to 33 hours. Next, please. So empty follicle syndrome. So it is basically a lack of oocyte retrieve despite adequate ovarian response on ovarian stimulation and meticulous oocyte. There are two types of empty follicle syndrome. One is a genuine empty follicle syndrome and one is false empty follicle syndrome. The false empty follicle syndrome is more common. It is mainly due to inappropriate trigger administration. There is lots of cold chain or if it has not been taken properly. Genuine EFS is very rare and it is mainly due to receptor polymorphism where the trigger has been given properly but maybe it has not acted on the receptors properly because the patient has a genetic problem of a polymorphism. Next, please. So if we have come across an empty follicle syndrome, so obviously most of the time, a lot of time what we do is we repeat a pickup that is 12 hours or 24 hours later, but most of the time we don't get that good of a yield. So in such cases, in next cycle when you are doing, it will be very nice if you switch to a long agonist cycle, and it has been shown to give you much better result as going for an anti cycle again. Next, please. So now the last topic would be suboptimal response to GnRH agonist trigger. It is commonly seen in PCO patient due to self-priming of the gonadotropin cell with high E2 and suboptimal delivery of the gonadotropins due to inadequate neovascularization owing to intermediate follicle. It is most commonly used in patient. It's most commonly seen in patient where we see there is more of stroma and the follicles are, but there is more stroma. So such problem we usually see in those patients. Post GnRH agonist trigger, the endogenous and FSH and LH could be inadequate. In such cases, a second dose of trigger, that is 12 hours after the first trigger, should be considered, which is double trigger, which is very commonly used now. Poor outcome or cancelled retrieval is seen when LH is less than 15 international unit 12 hours post trigger. So in cases of severe PCOS, I usually prefer to repeat a LH after 12 hours of a trigger. It really improves the outcome a lot because PCO patient, they tend to fall in these category. Next, please. Dual trigger. So we are aware of the dual trigger now. This is most commonly given. Dual trigger was first defined as a concept of combination of GnRH agonist trigger along with a low dose HCG in triggering the final oocyte maturation in high responder, because we could not give a high dose of HCG of 5,000. So it was mainly started for PCO and high responder patient. But it has shown to give better fertilization and implantation, if not better at par, but the risk of OHSs decreases significantly. Next, please. So the advantage is GnRH agonist trigger causes the physiological FSH and LH rise, and it leads to increased number of mature oocyte. However, the HCG will give the corpus luteal support. So we get the benefit of both. Dual trigger also tends to enhance the amphiregulin and epiregulin, epidermal growth factor these are, which leads to better cumulus expansion, oocyte maturation, and resumption of meiosis. Next, please. So double trigger, as I already discussed, double trigger is GnRH agonist is given at 40 hours before the pickup, and HCG trigger is given 34 hours before the egg retrieval. It prolongs the time interval between the trigger and egg retrieval, overcoming any granulosa cell dysfunction, further cumulus cell expansion. And it has shown to show an excellent result in cases where in previous cycle we have not got a good amount of egg as we were expecting, or empty follicle syndrome was there. Next, please. Thank you. So I hope the presentation was helpful for you all, and if there is any question, you all can please ask.
Thank you so much, Dr. Shweta. That was a great presentation. If any questions, please post it in the chat box. She'll be there to answer those questions. Swastika, can you give the next speaker's CV?
Ma'am, the next speaker is Dr. Purbasha, right?
Yes.
Okay.
Our next speaker is Dr. Purva Shah. He is a consultant at Sri Krishna Hospital, Borivali East and Akshit Hospital, Daisar East. He is also an advanced laparoscopic trained surgeon under Dr. Vivek Salarkar. Purva, please start sharing your screen.
I'll share my screen if you, yeah. Hello, everyone. And I would thank AFG and the President, Dr. Nitin Shah, for giving me this opportunity to talk on hysteroscopy, the future, office, ambulatory, and the flexible. To start with, we all know change is constant. We have evolved tremendously in the field of minimal invasive surgery in the last 1.5 centuries, and also in the field of hysteroscopy. To start with the history, it dates back to the late of the 19th century. The first one to perform hysteroscopy was Pantaleone in 1869 on a postmenopausal woman for a polyp. Later, in the early 20th century, there has been advancement in the field of distension media used for hysteroscopies. We have used CO2 initially. Later on, Gauss came up with water for distension in 1928. In 1970, we got introduced with hysteroendomet. 1990 came the era of vaginoscopic approach, the see and treat approach. In conventional hysteroscopy, what we used to do is we used to introduce a sim speculum, and valcellum was used to hold the anterior lip of the cervix. And then the cervical dilatation was carried on, which gave a lot of pain. So hence we always needed anesthesia, or at least some form of local anesthesia. But with the advent of vaginoscopy, all of this was an old traditional method. The distension media, which was widely used earlier, was CO2 followed by glycine, which is hypotonic, but it was a good non-conductive material to be used and suitable for monopolar electrocautery. But there was a risk of fluid overload and hyponatremia with glycine, and there had to be constant watch on the input and the output. If the input-output deficit was crossing more than 750 ml, we had to abrupt the procedure. There has been shift surely. Initially, we used to always do is blind dilatation and curettage or even biopsy. Later on came see and treat biopsy under anesthesia. Today, we are at see and treat in the office setup itself. All of this is made possible is by the advancement in the size of hysteroscopes, better visualization. There has been advancement in the science technology field. Also, we have got HD cameras, 4K cameras. Also, the media has changed. The distension media I talk of. They are more safer and easily available like normal saline. And hence, we have got a game changer office hysteroscope. It is nothing but a procedure of hysteroscopy done in the doctor's clinic without the need of general anesthesia. How is it possible? It is by the no-touch technique, vaginoscopic technique, the continuous flow system, which helps in visualizing the field, which is clearer, and also cannot thank the telescope of 2 mm and with an outer diameter of 4 mm, which is almost atraumatic for the patient. Here's a look at the vaginoscopic technique. What we do in vaginoscopic technique is we introduce the hysteroscope into the vagina, we go towards the posterior fornix, and then come out a little, try to trace the entire circumference of the cervix. As soon as we point towards the external os, we try to hook the hysteroscope into the external os. Then we are negotiating through the cervical canal. Once we are about to reach the internal os, what we do is a little of massaging by rotating the light cable from 3 o'clock to 6 o'clock position. We try to keep the location position of the light cable at 3 o'clock once we are entering through the internal os, so as to avoid the brushing of the endometrium. And here we see is a polyp also, and fundus with a little of septum, probably a metroplasty needed in this case. Professor Bertocci has used this vaginoscopic technique for over 11,000 of patients, and he has published this data that 99.1% of his patients had no discomfort related to the approach of this insertion of the scope into the cervix. Now comes the question, is every patient eligible to have an office hysteroscopy? Yes, if the selection is right, we as surgeons have to select the cases, the size and the depth of the pathology, the patient willingness, the comorbidities, and our skills play an important role in selecting the patients for office hysteroscopy. On a lighter note, almost all the diagnostic procedures, all the second look hysteroscopies, abnormal uterine bleeding cases, infertility evaluation, polypectomy for smaller cases, smaller fibroids can be dealt on an office basis. Also, we need to remember that these patients have to be counseled well before the procedure. A complete procedure has to be explained. They have to be sensitized that the water is going to flow through the vagina and into the uterine cavity. All of this has to be explained prior to the procedure. And also, they can be explained that the procedure can be terminated at any given point of time if they face discomfort, but they have to be vocal about it. And also, we as a surgeons need to know that we need to avoid this office hysteroscopy in cases in people who have sleep apnea or cardiopulmonary disease, or even those anxious personality people. It is better to do these cases under anesthesia. With office hysteroscopy, the major problem was we couldn't deal with polyps, we couldn't deal with fibroids which were not treatable via cold scissors, where we needed a resectoscope, because the resectoscope sizes available at that point of time were 26 French. So we always needed is a dilator, which used to always inflict pain to the patient, and hence the anesthesia needed. So Gubini introduced a mini resectoscope. Originally it was 16 French. Right now we also have 15 French available resectoscope, which offered office polypectomy or myomectomy without adding discomfort to the patient. But it is always suitable for sizes of a polyp lesser than 2 centimeters, as the time taken for the procedure completion is more if the fibroid or the polyp size or the pathology size is more than 2 centimeter, and hence increases the pain. With the resectoscope, we have resected chips obscuring the field of operability. There's also the prolonged surgery time. Also, you require cervical dilatation for resection, the tissue retrieval if the pathology is large enough. And also there's a risk of perforation. Hence, we came up with hysteroscopic tissue removal system, which uses mechanical energy over electrical energy for uterine tissue. It has an inner tube and an outer tube. Inner tube which does the suction and the outer tube which does the morcellation. And hence, the larger pathology can also be removed without the need of tissue retrieval. The available devices in the market are TrueClear and the MyoSure. MyoSure is 6.9 mm. But we also need to know that this system can be used only is for myomas type 0 and 1. Rarely anyone has used it for type 2 myomas. There has been a review of 8 studies from 2005 to 2015 that shows the operating time reduction is significant with HTRS system. And out of this 8 studies that has been reviewed, only 3 have done this HTRS under office procedure. The rest all have done it under anesthesia. And they all have done it for type 0 and type 1 myomas. None have done it for type 2 myomas. Here's a look at the polypectomy with cold scissors done in office procedure. Hysteroscope was introduced and a polyp was diagnosed on the left lateral wall. With the cold scissors, the base of the polyp was separated, and using the grasp technique, the polyp was removed along with the entire set. You can see, and the polyp could be sent is for the histopathology, which is always needed. This case was a classic example of one-stop postmenopausal clinic solution. She had come to us with 4 days of postmenopausal bleeding. And when she came to us, we asked her for a sonography. We did a sonography in the office setting itself. We could see his 2 by 3 centimeter polyp. We explained her the procedure of office hysteroscopy, and she willingly accepted. She also understood the earlier the diagnosis, better it is. So we took her for office hysteroscopy. What we could see was a 3 by 4 centimeter polyp with very high surface vascularity, looking more of cancerous than a benign condition. We could take a biopsy from this and we could send it for histopathology. Within 4 days, what we got is a report of suggestive of adenocarcinoma FIGO grade 2. The patient was on the table for surgery hysterectomy after 5 days. We could save a lot of time. This is another video showcasing the same atrophic endometrium with few submucosal polyp and a fibroid. This video demonstrates a submucosal myoma resection via resectoscope slicing technique. The resectoscope via slicing technique is taking a slice of myomas and accumulating in the uterine cavity. As already mentioned, this is a drawback of the resectoscope in an operating because we need to remove all of these bits. Not necessary, you can always leave behind these bits of tissues in the uterine cavity. It is going to come out irrespectively. Always to remember submucosal myoma, if they are on the opposing wall, if they are large enough to operate in two different settings, because the chances of Asherman syndrome adhesions are very high. This patient had come to us with 3 failed ovulation induction cycles, and the sonography was very much normal. But with 3 failed ovulation cycles and everything normal, his HSG was not done. We asked her to go for an office hysteroscopy, and incidentally, we came across the septa. We did is resection via cold scissors. You can see the cold scissors have been used for the resection. And what we do is we try to maintain the concavity of the fundus and try to mark the amount of the septum that is to be resected. The advantages of the office hysteroscope is we can immediately see, precisely diagnose the patient and then treat it at the same setting itself. It helps in better triaging. It decreases the chances of infection. The recovery time, the comfort of the patient is amazingly good, and also it's pocket friendly for the patient. Complications of office hysteroscopy are more or less the same as traditional hysteroscopy. The rate of infection, the rate of perforation are almost same as that of traditional hysteroscopy. There has been a study published on a long-term complications of office hysteroscopy on over 1,000 cases, of which 60% of the cases were diagnostic, 32 were therapeutic, and almost 8% of these procedures failed, probably mainly due to the cervical stenosis, of which only one patient had complication on a long term, and the complication was low-grade fever. On proper investigating, proper sonography after the complaint, nothing significant was found relevant enough to the hysteroscopy procedure. Also, we need to remember with office hysteroscopy, there comes pain and a vasovagal attack. This is mainly on negotiating the internal os or when the intrauterine pressure is high, which may give a vasovagal attack. This is very easily takeable by supportive measures like raising both the legs, changing the Trendelenburg position. Also, preoperative counseling helps in minimizing the anxiety and reducing the pain score. Always need to remember to keep atropine ready in case of an office hysteroscopy. There are few people who are using mefenamic acid, NSAIDs, also using paracervical blocks in office hysteroscopy, but none of the studies, including I, have never seen any of this to be used in an office hysteroscopy. They prove no added advantage over a placebo. To mention a fact, there is a fear of complication with hysteroscopy. Despite of having all of the data, despite of showing a very low complication rate of 0.28%, post hysteroscopy, only 30% of the gynecologists are performing operative hysteroscopies. And also to compare office versus operating room procedures, the traditional hysteroscopy, the pain, the time taken, and the post-procedure infection rate are very less. And the failure rate is almost comparable, or there is no difference to the traditional hysteroscopy. Moving on to the ambulatory hysteroscopy or outpatient hysteroscopy, it is nothing but performed in a semi-formal operating rooms or outpatient department with or without analgesia. It is being often interchangeably used with office hysteroscopy. But being in a semi-formal operating rooms, you can do more complex or time-consuming operating procedures. Indications and benefits are same as of office hysteroscopy. Flexible hysteroscope, they are thinner than the rigid hysteroscopes. The available size of the hysteroscopes are 3.1 to 5 mm. They have a long working sheath, which is a fiber optic bundles, operating channel, and a channel for distension media. With the development of newer fiber optics camera and the video system, the image resolution has improved tremendously. Now we no longer have the grid-like images, but still the images are smaller than those of the rigid hysteroscopes. The advantages are we have a panoramic view. We also have angulations which help to visualize all of the uterine cavity, even in the most difficult to access by rigid scopes. The distal tip of the flexible hysteroscope with two-way angulations allows for negotiation. Hence, even in acutely antevated or tortuous cervical canal, the negotiation is easier and painless. But the major drawback with the flexible hysteroscope is nothing but a higher cost and lesser durable than the rigid hysteroscopes. With time, probably will overcome this also. The available flexible hysteroscopes in the market are by Olympus and the Karl Storz. Karl Storz and the Olympus, both of them use 0-degree telescope. And Karl Storz system has a 4 French working channel. Also, semi-rigid flexible scopes are available by Versascope. I would conclude by saying hysteroscopy is beneficial for both patients and doctors. It helps in early, precise diagnosis and treatment. It also reduces burden on the operation theaters. It is cost effective both for the healthcare providers and the patients. and the comfort of the patient is to the next level. Immense potential to become more accessible, precise, and less invasive. We have come a long way, but still we have a long way to go. My take-home message is see and treat is a need of the hour along with patient convenience. Office hysteroscopy is a one-stop solution for gynec patients with abnormal uterine bleeding, postmenopausal bleeding, infertility. To see is to believe. Hysteroscopy is a visual trait. Thank you.
Thank you, Dr. Purva. That was quite engaging, and you took us into the future of hysteroscopy from the present.
Thank you so much, sir.
I would like to take this opportunity to welcome our MMC observer for this evening, Dr. Ketki Gupte, madam. Madam has taken a time out on behalf of MMC. Welcome, madam. This is our webinar conducted by the AFG for the youth, by the youth. And these are all our rising stars and busy practitioners, endoscopists, IVF specialists. And this is a platform that we have given them to showcase their talent. So welcome, madam. I would now like to move on to our next talk for the evening. Can we have the CV of the next speaker, please? I would like to welcome Dr. Anand Nanavati, our next speaker. Dr. Anand is consultant IVF specialist at Create IVF Mumbai. He is visiting consultant at Nova and Surya. He's worked for a long time in the UK at James Cook University Hospital, and he's also an MRCOG examiner. Welcome, Anand. Over to you.
Thank you, Dhaval. Am I audible?
Yes, sir, you're audible, sir.
Okay. Is it possible for me to share my screen? So you'll have
Yes,
to.
sir. Want you can also share.
Sorry, I'm very technologically handicapped, so you'll have to help me.
Okay.
Can you see my screen?
Yes, sir. The screen is visible. So,
You can see
answer.
it.
There is a small options coming as app zoomers and sharing a screen, and you can just hide that. Hide that.
Okay. Yeah. Okay.
Yes, sir. And now
No,
go back to your PPT, sir.
no, sorry, 1 minute. I think I lost it again.
Swastika, could you share it for him then?
Yes, I can also share it if you want.
I'll just try once more. Just try once more. Sorry. Yeah. So, is it okay if I don't hide? Can you see it, or you can
Yes,
still
sir.
see it?
You can go ahead if you want also.
Okay. Yeah, okay. So, sorry for the delay. Good evening, everyone. Thank you, AFG, President of AFG, Nitin Shah, sir, Dhaval, for giving me this opportunity to speak on this topic, which is very close to my heart. 20 minutes is a little less time for giving justice to this topic, but I've covered the important points. So my topic is role of embryo biopsy in today's era. And to start with, I would like to go through the history and evolution of this procedure. It all started in the 1890s, where scientists were performing animal embryo biopsies, and it almost continued, to perfect anything you need more and more practice. So it went on for almost 100 years. Not up till 1990, the first human embryo was biopsied by Professor Handyside, and he did it for to detect sex-linked diseases and X-linked mental retardation using polymerase chain reaction. In the early 1990s, the lab technology that was used for genetic analysis was FISH. Now, as you know, FISH only detects genetic abnormalities or chromosomal, structural, and numerical abnormalities in 5 main chromosomes, that is 13, 18, 21, and the 2 sex chromosomes, and a few microdeletions. So there was a need for another test which could obviously analyze all chromosomes, and that was it. In 1999, comparative genomic hybridization helped us analyzing all the chromosomes. And as the technology advanced, use of SNP, that is single nucleotide polymorphism, and next generation sequencing made it even more accurate. And currently, the most common used technique is NGS. Now, when it comes to embryo biopsy, the tests that are relevant depends clinically. There are 3 main tests that we do. One is PGT-A, that detects numerical aberrations in the chromosome, such as detection of trisomies or monosomy like Turner syndrome in an embryo. PGT-SR detects structural rearrangements in the chromosome like translocations, certain inversions, and these embryos might be causing miscarriages to the couple. PGT-M detects a single gene disorder in embryo, so you can identify the embryo carrying cystic fibrosis, Huntington's, or even thalassemia. So, what are the common indications of embryo biopsy? The most common indications are recurrent miscarriages, previous anomalous babies, advanced maternal age, recurrent implantation failure, such as if 4 good quality blastocysts have transferred and you've not got a success, then you can test the embryos, severe male factor infertility, and couples which are carriers of single gene defects such as autosomal recessive, autosomal dominant, or X-linked gene disorders. Now, when it came to embryo biopsy, again, the evolution was that it started off with a polar body biopsy. And so, polar body is extruded basically once the embryo, the egg is fertilized from the sperm. But that was not fruitful at all because you're just analyzing one cell and the embryo is not even being made. So then, as the technology of culture media improved, we started culturing the embryo till day 3. Day 3 is a cleavage stage biopsy with around 6 to 8 blastomeres in them. And out of the 8 cells, we could again we biopsy or just take out 2 blastomeres, 1 to 2 blastomeres for genetic analysis. That was an improvement from polar body biopsy, but still not fruitful because again embryo has not reached up to its entire potential, and it's not a representative sample of the embryo again, and also there was more embryo damage. Now the gold standard is a blastocyst biopsy, and in a blastocyst biopsy you have your inner cell mass which forms the baby and the outer cell layer which forms the placenta which is called as a trophectodome, and we take out 5 to 10 trophectodermal cells and send it for genetic analysis. Now, this is a small video taken from my own lab. So this is, you can see the embryo being held. There's a suction pipette, and the embryologist is sucking the trophectodermal cells gently. Around 5 to 10 cells are taken in the pipette. The red dot is a laser. So the laser, once the tenting is done, a few shots of laser is given. We release the embryo, and this is called the flicking technique, where the pipette is, now if you can see, just gently flicked against the holding pipette, and the genetic material is dislodged from the embryo. This is the most commonly performed technique, and this genetic material will be sent for testing. So now that you've sent the genetic material or the trophectodermal cells for testing, the lab will culture it, perform NGS, and what are the different results that you can get? So obviously the most common, the first result that you can get is it's a euploid embryo. So euploid result is given when less than 30% of that genetic material shows abnormal chromosomal distribution, or in other words, 70% is showing normal chromosomes. So these embryos, can we transfer? Yes, of course you can transfer. Second is aneuploid, where more than 70% of the material is showing abnormal cells, and you should definitely not transfer these embryos. Now, third is, I want to talk about this. Now, this is mosaicism. Mosaic or mosaic. Mosaic in Latin means different. It's different cell lines in an embryo. You can see an embryo can have abnormal cells and a mixture of normal cells. So what to do when you have this kind of a result? So there are levels of mosaicism. One is the low level mosaic, where in the genetic material, 30 to 50% of the material shows abnormal chromosomes. Majority shows normal. So can you transfer this embryo? Yes, you can consider transferring, but you have to tell the patient. So you have to reassure the patient that majority of the cells are normal. The embryo has the propensity to self-correct also, and there's a theory that embryo shifts the abnormal cells towards the placenta, towards the trophectodome. So most probably the ICM could be normal, but at the same time, if we are transferring, do not let go of the third month combined screening, which is your NT scan with dual marker test or an NIPT. High level mosaic is when 51 to 80% of the cells are showing abnormalities. Most clinicians don't transfer these embryos. The fifth result is no DNA can be obtained. Sometimes it happens where there is no DNA that was cultured. Usually happens when you are doing a embryo biopsy on a poorly graded embryo, where the trophectoderm is not well formed. In these cases, again, you have to counsel carefully, tell the patient that it's probably a poor grade embryo, may not survive a rebiopsy. If they're still keen, tell them that, okay, you'll have to, these embryos are frozen, you'll have to thaw, again rebiopsy, freeze again, thaw again, so that can affect the implantation potential of the embryo. Now we come to mito scoring of the euploid embryos. Let's say you have got euploid embryos and you want to decide which one of the euploid embryos should you transfer first, because the whole idea in IVF is to decrease the time to pregnancy. So mito score is a value that measures the amount of mitochondrial DNA found in the euploid embryo. Higher the mito score means more energy expenditure by the embryo, and that leads to decreased implantation potential. So this is a report of an actual patient, and I'll be discussing the case scenario in the next slide. We had 6 embryos, 4 were aneuploid, 2 euploid, and which one did we go ahead? So we obviously went ahead with the one with the lower mito score, implanted that, and she got a positive result, and she has a healthy baby boy. So, few case scenarios to discuss. The first case scenario is regarding that patient. She had 3 spontaneous pregnancies. The first pregnancy, natural conception, went ahead fine. And the third month, 13 weeks, she had a thickened NT. A CVS was performed, confirmed that the pregnancy had trisomy 21. They decided to terminate that pregnancy. Second pregnancy, again, natural spontaneous conception, miscarried at 9 weeks. DNC was done, karyotype was done, which showed normal karyotype. The third pregnancy diagnosed again with at 10 weeks, there was a swelling in the neck called a cystic hygroma. She decided to terminate, and a chromosomal microarray was performed, which showed Turner syndrome. This couple was obviously very distraught. They came to us. We counseled them. We made sure we did their karyotype. Parental karyotype is very important here. They both were normal. Ruled out APLA, ANA, that was negative. Counseled for PGTA. We had 6 embryos as shown in the previous slides. Only 2 were euploid. We did a single blastocyst transfer, and she had a successful live birth. So did she benefit from PGT? Yes, of course she did. Second case, this is a couple which had a consanguineous marriage. They were first cousins. They had a natural conception, 8 weeks, had a missed abortion, underwent a DNC, but karyotype was not done. Second time they conceived again, they had an ectopic pregnancy, which was medically managed. And then they were struggling to conceive. So they went for IVF at a very well reputed center. They had an IVF done. One embryo transfer did not work. Second embryo transfer, she worked. She had a positive pregnancy. But unfortunately, in the 5th month, it was diagnosed to have a tetralogy of Fallot. And she had to terminate that pregnancy at 20 weeks. DiGeorge syndrome is something where tetralogy of Fallot is found in DiGeorge syndrome, but that was ruled out. Karyotype of the fetus was also normal. Parental karyotype was normal. So we counseled her for a whole exome sequencing. It's a very advanced genetic test which rules out any other genetic causes for this outcome. But she refused. They just opted for a simple PGTA. We had 9 embryos, 9 blastocysts, and all 9 had complex aneuploidies. Now, did she benefit from PGT? Yes, because somewhere PGT also gives the couple a closure. Had we not tested these 9 embryos and started implanting, she would have had negative IVFs or even worse. Third case is a case of PGTM. This couple both had thalassemia trait. Knowing that they had thalassemia trait, they were in another city. The first time they got pregnant, they opted to continue the pregnancy. And the gynac then counseled that, you should do a screening. So they opted for CVS at 13 weeks. Baby was diagnosed with thal major. She had a medical termination followed by DNC. It was quite traumatic. She suffered severe blood loss. 3 units of blood was transfused. And then we obviously she was referred. She had come to us, and we counseled them for IVF and PGTM. So the flow in PGTM is that you go through a thorough genetic counseling. A geneticist will take a detailed family history of which are the other family members that are carrying this gene. then the couple has to go through a pre-PGTM genetic workup where blood tests are done on the couple and also if possible, for the other family members to identify what are the possible mutations that can be detected. Once you've identified the mutation, you have to prepare the the lab will prepare the genetic probe according to the mutations identified. It's something like a sniffer dog. You're training the sniffer dog to sniff out blood or whatever you want them to get trained for. Then she underwent IVF, day 5 culture. And initially, we have to do PGTA because you want to rule out the aneuploidic embryos first. There's no point doing PGTM and then inserting an aneuploidic embryo. So PGTA was done, and then only on the euploid embryo, PGTM was performed. We obtained 5 good grade blastocysts. PGTA showed 2 aneuploid embryos, and then on the 3 euploid embryos, we did PGTM, and only 1 was normal. We inserted that one. She had a positive pregnancy, and currently she has a healthy baby girl of 2 years. The last case, now this is a little bit of a paradox where PGT was not beneficial, and I wanted to show this because it does not mean that you keep doing PGT for everyone. This couple had a spontaneous conception, miscarried at 7 weeks in the first pregnancy. Second time again miscarried at 9 weeks, and that time DNC was done. Products were sent for karyotyping. 69XXY was found. We counseled for PGTA. We got 3 embryos. There was 1 euploid embryo, and I remember at the time of when we thaw these embryos, we have to see for expansion even after biopsy. I know I'm not mentioned in the slide, but something important is even after a biopsy, we wait for an hour. We see whether post biopsy the embryo expands or not. And I remember that her embryo did not expand very well as well. And even after the thaw, it didn't expand completely. We transferred it, but unfortunately, it didn't work. Could be that the embryo did not survive, or it could be that there could have been mosaicism where you are only taking 5 to 10 cells which would have shown euploid, but the rest of the embryo might have been aneuploid. We don't know. But luckily, after 2 years, she spontaneously conceived and delivered a healthy full-term baby. Another lesson is sometimes waiting and giving a break is also helpful for patients. But yes, she did not benefit from PGT. So what are the challenges of embryo biopsy? It's costly. You need a laser, you need the disposables, lab charges, the NGS charges are expensive. There is always a small risk of embryo damage, although blastocyst biopsy has a lesser risk of damage than cleavage stage biopsy. Mosaicism is always there. You may be implanting an embryo which shows euploid, but the rest of the cells, rest of the majority of the embryo may be aneuploid, and there's a risk of failure or miscarriage, or vice versa. You may be discarding embryos which only those cells showed aneuploidy, but the rest of the embryo may have been fine. And obviously, there's a steep learning curve, and it's very technical, and you need an adept embryologist to do this. Something about non-invasive pre-implantation genetic testing. This came a few years ago. The theory is that you keep the embryo in the culture media. The embryo exfoliates DNA, and that DNA, the media surrounding the embryo is taken and sent for testing. There was a lot of promise in this because it's non-invasive, less expensive. The theory is that it's not only the trophectoderm cells that we are taking from the PGT, the cell-free DNA that has been exfoliated is from the entire embryo, that is your ICM and trophectoderm. So it's a good representation of the entire embryo. But there came a lot of disadvantages, and the main disadvantage was media contamination. Even a small aerosol, exfoliation of skin cells from the handler or the environment were causing DNA contamination, leading to false reports. A very good center in Australia, retrospectively studied their results in NIPGT, and then they realized that they were selecting even poor grade embryos because they were shown euploid. And those poor grade embryos would have been discarded, and we wouldn't have done PGT. So led to a lot of failures as well. And just a few weeks ago came a joint statement from the president of ISAR, Dr. Amit Patki, Dr. Pankaj Talwar, IFS, and ACE, Dr. Sujata Ramkrishnan, very clearly written that do not use NIPGT because it's not proven to be beneficial and more research is needed. Some newer technologies, since we're talking about today's era, some newer technologies now, if we get aneuploidy, what are we going to do? We don't transfer, but we never knew what the answer was. Who was responsible? Was it the egg or the sperm? So there's a test called EmbryoSure, which uses SNP technology, where you again rebiopsy the aneuploidy embryo, take the blood sample from the partners, use SNP, and then identify what is the source of aneuploidy. Is it the husband which is responsible? Is it the wife which is responsible? So then you can obviously go for donor egg or sperm, respectively. This slide, it's not very relevant for embryo biopsy, but I thought it is very fascinating. This is something about embryo cleaving. It's obviously, this is research. It's not used in clinical practice. In China, they are using CRISPR-Cas9 technology. These are it's like a virus. It's like basically like Pac-Man. How Pac-Man, if eats away the unhealthy tissue. This specific cell goes and eats away the abnormal cells or abnormal cells containing trisomies or a particular gene which you don't want, and basically genetically modifies the embryo. But this is all research. It's just fascinating, and we'll have to see what happens next. So take home points here are that PGTA for all should not be recommended. It should be done only for indicated cases. Biopsy should be done of a blastocyst only. Do not do cleavage stage biopsies. Biopsy should ideally be done on fresh embryos rather than frozen embryos, because the thawing, freezing can decrease implantation potential of the embryo. You should always have an MDT approach, involve a good geneticist, have a competent embryologist, a good genetic lab, and an equipped IVF lab. Most important take home point is honest and thorough counseling. Be very honest to the patient. Explain to them that just because you have an euploid embryo does not mean that 100% it's going to work, just as what has happened to our patient. And we told her honestly that it's not always 100%. And there can be mosaicism, there can be embryo damage, and that will help you. NIPGT should not be performed till we have more robust data. So thank you for this presentation, and thank you for the opportunity. I would like to take any questions if there are any.
If there are questions, we could have them in the chat box. Maybe Anand could take them later. I would like to make a mention of two things. One is that the USP of this UA webinar is we leave the choice of topic entirely to the speaker. Now, why I'm mentioning this right now is when I spoke to Anand regarding this UA webinar, he came up to me and told me that we do a lot of embryo biopsies, so I would love to speak on it. And I said, you can go for it. So it applies to all speakers who've been a part of this series. We are going to have 3 to 4 more Yuva webinars this year. And we are welcoming all our youth to come up with topics of their choice and use our platform. Second thing, a big shout out to Monica. You're doing a great job as MOC. And you've also done a lot of background work. So keep it up. And we are waiting for your talk in the next webinar.
Yes, sir, definitely.
Over to you.
Hello, Anand sir, can you please stop sharing your screen, sir?
We would like to thank our sponsors for our Yuva webinar, which is SUCAM system, surgical medical grade monitor and video recorder and microscope video camera. This is their address, and we'll also be sharing their number. You can always contact them for further details. Swastika, can you share next speaker CV? So our final talk for today is Dr. Somil Trivedi, sir. Sir is a co-director at Dr. Trivedi's Total Healthcare and Akar IVF, youngest IAG Managing Committee member, also has received multiple awards, and also an author of 13 publications and 49 book chapters. Over to you, sir.
Thank you so much, Monica. And firstly, at the outset, I would like to thank AFG, our president, Dr. Nitin Shah, sir, Dhaval, and all the workers of AFG who have worked and taken AFG to a really great height this year. we're seeing so many activities from AFG this year, which is really promising and a good thing to see. So I hope my screen is seen.
Yes, sir, it seems.
So the topic that I will be speaking today on is moving away from the IVF and the advanced uh, techniques in IVF. I think I'll be speaking about the advances in endoscopy, and my topic that I have chosen is the Green Revolution, moving to the unseen realm with the world of ICG and its varied applications. So ICG basically is a lyophilized green dye which has varied applications, and it's not something new. It has been around since 1959. It's just that now the technology is promising and we can use it in various potential unknown ways which were previously unheard of. So the potential ways of administration of ICG, it can be given intravenously, as we all know, cystoscopically into the ureters, intracervical when we are talking about sentinel lymph node biopsies, transcervical into the uterine cavity, and into the utero-ovarian ligament. These are the various sites and approaches via which ICG can be given and used in various applications. So the potential applications in benign surgeries, we all know that there can be complex pathologies like endometriosis, large distorted fibroids, distorting the uterus and the anatomy. And in these cases, ureteric delineation is very important to safeguard the ureters and vital organs. It can also be used for perfusion assessment of something as basic as the vaginal cuff post hysterectomy when given intravenously, in ovarian torsion post detorsion to know whether this ovary is going to have future viability, bowel anastomotic sites after resections, and in tissue identification, especially in endometriosis. Although there is various literature that proves that it does not help us delineate the nodules per se, but the poor uptake of ICG can guide us in the dissection and delineating effects like isthmocele and aiding their correction. So I'll be presenting a series of videos. This is the first case, which is of a large fibroid uterus. When we are having such a pathology, this MRI also did reveal that there was some back pressure and compression on the right ureter. So we have gone cystoscopically and injected diluted reconstituted ICG dye into the ureters. We normally dilute the powder in 20 ml of NS, and usually around 5 ml to max 6 ml per ureteric orifice after the ureteric catheter is enough for us to delineate the ureters. So this, I would say, despite the size of this large fibroid, this was a very easy case because what you saw there was that the pedicle was hardly 5 to 6 centimeters. But what was a challenge is that we could only visualize the ureters once this fibroid was removed. And this is where on switching on the NIR, that is the near infrared mode, this is the monochromatic mode, and the earlier one was the overlay mode, wherein we see that it is just compression and the ureteric integrity can be very well appreciated, which would have been a challenge otherwise. As usual, we proceed with a contained morcellation, and once the entire morcellation is complete, uh, the final picture, it is reassessed and we are seeing the entire ureter in its entire length, and we confirm the hemostasis. We're also seeing some uptake in the urinary bladder. Similarly, in cases of difficult hysterectomy, large uterus, or distorted pathology, I will not go through the basics. Steps of any hysterectomy would be fairly standard. This is almost a 26-week size uterus. We can, in fact, very beautifully visualize. This is, I think, just immediately after the installation. So we are not seeing that much of a green uptake as of now. As I mentioned, the steps of hysterectomy are fairly standard. We begin laterally, separate the cornual structures, and then we are dissecting the leaves of the broad ligament. The posterior fold is then dissected. Just having this technology, it gives a buffer or a cushion, which like gives us a little bit more confidence in doing such difficult cases, knowing that we are away and safe from all the vital structures. So even though this is a hysterectomy, I prefer to instill some amount of vasopressin, especially if I'm going to use a myoma screw in such situations. When you're dissecting anteriorly, obviously, I don't need to see where the ureters are. The bladder dissection in such cases is usually fairly straightforward because the bulge or the protrusion with the fibroid only aids the dissection and makes it much easier. So skipping ahead, the first step wherein I felt the need to switch on to the overlay mode was once we finish this anterior dissection, we will be going posteriorly and targeting the posterior leaf of the broad ligament on the right side. And that is when I felt the need that it is better I just visualize where the ureters are, and that is when the mode is activated now. And we can see that the ureter is at a safe distance from our line of dissection. We are remaining on top, and before coagulating the uterine artery, I have visualized nicely that the ureters are indeed at a distance and the uterine arteries can be coagulated safely. So this is again on the left side. We are seeing that the ureteric glow is seen pretty lateral compared to where we are. We proceeded ahead with the hysterectomy and opening of the vault, and once the entire process is completed, again identified and were safe and knowing that we have not caused any damage. Now, coming to endometriosis, the only reason I want to highlight this, there is one limitation with the ICG dye is that the depth of penetration when you activate the near infrared mode is not very high. So what I mean by that is that you cannot just put on the dye and assume that you will just see the ureter. We will have to unmask or unearth or remove of the diseased peritoneum for us to be safely able to visualize the ureters. So in this case, there was some amount of right ureteric involvement and parametrial involvement, wherein there was an extrinsic compression of the ureter, and we are going ahead with the medial pararectal space dissection and identifying the ureter at the pelvic brim. We are nicely seeing the ureter out there, and we can see an area of constriction which is right about there. This is when I feel that, okay, I need to probably, like just make use of technology and instill ICG. And that decision has now been taken, and cystoscopically, we have injected. It takes about 10 minutes for us to see some amount of green hue. So it is not going to be immediate. Although in this instance, like the ureter was pretty well seen. But what I want to highlight out here is that if you compare the right side to the left side has a lot of diseased peritoneum. Uh, I have a principle of, like go from the virgin area to the affected area. That is, go from the normal to the abnormal, which is in line with standard laparoscopic principles. Because on doing the simple things first, you will realize that these complexities later on are not very challenging. So even though the overlay mode is right now on, we are not seeing very visibly the ureteric glow. So I decided, all right, I will tackle it probably a little bit later. Go ahead with the easy parts, finish off the anterior dissection. And there are a lot of surgeons nowadays who are, I would say, doing this radical peritonectomies and everything, which does have a role, but it is not something which is required in absolutely every cases. You see a lot of videos these days wherein, like absolutely normal looking peritoneum is excised in belief that there is some imaginary endometriosis. Now, in this cases, there is a role of the removal or excision of partial peritoneum or the affected peritoneum, not necessarily, like a total peritonectomy or anything. So again, we are step by step removing the diseased peritoneum. Essentially, this is the right ureter, and the nodule on top is now bivalved so that it is split into two and the ureter is completely free. We again go into the left pararectal space, mobilize the rectum completely, take care of the rectovaginal disease, which in this case was limited and superficial and could be managed just by rectal shaving. This is again just identifying. What we are seeing out here is now that we are seeing the ureteric glow, and on top of it is a normal healthy looking fat and no diseased or affected peritoneum or a nodule. So how it helps us in endometriosis is that by just pushing this dye, we know what exactly we need to excise. It will not give us an uptake key, okay, this is the endometriotic nodule or this is not. So it just gives us a guidance or a reference point And at the end, since this was an elderly lady who had presented to us, this is the final picture wherein the uterus and bilateral ovaries and excision of the entire disease is done. Now, there is a false myth which I want to clarify. Whenever we say ICG, many people find it synonymous with onco-surgeries, and hence I'm going to focus mainly on the benign applications, which are enormous. Isthmosele, as we all know, is the disease of probably, I would say, the last decade or maybe even less than a decade, wherein earlier we were seeing isthmoseles left, right, and center, but not doing anything about it because that entity was not very well understood or not very well known, and its implications were not known. So this is ICG dye which has been put into the uterus, and it helps us objectively delineate the weakest area or the point of the isthmosele. Obviously, the same can be done via transillumination. That is, you put in a hysteroscope and dim the light of the laparoscope and see it. But sometimes it requires, like fidgeting too much with you need to have two light sources, or it requires moving the light cable here and there. So this gives us some amount of objectivity, and the weakest area is delineated already in front of us. And we can methodically excise and take out all the fibrotic parts, and then just reconstruct this defect well. Now, coming to robotics, the same technology, that is the ICG technology, along with its Firefly mode, has been in place since a very, very long time. In the right side, you are seeing a case of an adenomyotic uterus, wherein I'm doing an adenomyomectomy. On the left side is a bladder endometriotic nodule. The if you saw on the left, that backfilling of the bladder happens so fast because we use CO2. So CO2 sometimes is good to backfill the bladder because it immediately distends, and when we want it, we don't have to again, like put in the catheter and allow it to drain and give time. When we want to deflate it, the CO2 just comes out because it's just gas. So I want you to focus on the left one here. Obviously, in the bladder nodule, the principal important thing is separation of the bladder, which we have done methodically. This was interestingly, as probably if you have seen in the MRI, it was a partial thickness nodule. Now, shifting your focus from the left one to the right one, what I want to say is that this is an adenomyotic uterus, wherein we are doing an adenomyomectomy and pushed ICG dye into the uterine cavity to help us delineate the extent of excision, probably which we want to do of the adenomyoma. We all know that adenomyoma surgery can be sometimes a nightmarish surgery, wherein we don't know how much to excise so that we can suture. Also, at the same time, even though there is a school of thought which believes we have to intentionally open the endometrial cavity, I think the worst thing that one can do, especially if the patient is seeking fertility, is open the cavity, even though the age-old Osada technique tells us to do that, because it causes immense adhesions later. And we all know the mechanism. It's basically invagination of the endometrium into the myometrium. So by opening the cavity, we see sometimes that the rebound adenomyosis is doubly quicker, and hence I have a principle of not opening the uterine cavity at all if feasible. So that marks the end of the adenomyoma excision. We'll again use the ICG, and we are seeing this beautiful green glow of the endometrial cavity. Now, shifting your attention again to the left inset, is we have basically knocked out a major part of the bladder nodule. And the same basic principle, like how we were delineating the uterine cavity, here we are using ICG dye to delineate the bladder mucosa. And step by step, slowly, we are just ridding it. We are seeing the slight greenish hue, which is now coming into picture. So slowly but steadily and surely, we are excising this, safeguarding and precisely excising only the diseased part. It's very easy because you can obviously, excise the mucosa and just put a stitch and put in the catheter. But this just helps us be a little bit more precise and be less radical than what probably would be required. So at the end, this is the picture wherein the mucosa is nicely pouting out. The glow of the ICG dye is beautifully seen, and the bladder is then reconstructed, and catheter is kept for 7 days. Uh, this is one of the most interesting use. that I find that because a lot of young patients, like at ages of 9, 12, present with ovarian torsion, and we see this picture wherein the ovary is seeming gangrenous, and people just blanketly do a oophorectomy and salpingo oophorectomy. My urge to each and every one is that please do not do an oophorectomy even if it is appearing gangrenous. We have seen cases wherein the mass has been even up to 28 weeks. Just detort it, follow up with sonography, explain and counsel the patient that in case if there is pain, we need to see you and manage you. But don't be surprised that most of these patients, the ovary returns back to normal. Like a 28 week size uterus I have left, that is the pre-op size. After my surgery, the mass was still 24 weeks. And in 2 months, I have seen that the ovary is back to normal. So again, the ICG mode and the NIR system just basically gives us some ray of hope in terms of objectifying that, okay, we are seeing some amount of greenish hue. So there is going to be some amount of perfusion and return of blood supply, which can objectify our decision making. Now, as I said, I wanted to cover mainly the benign applications, but we all know that it has a major role in sentinel node biopsies, especially in early endometrial cervical vulval cancers, also in para-aortic node identification in borderline ovarian tumors when we inject it into the utero-ovarian ligament. And in malignancies, again, if bowel resections are done, we can confirm the anastomotic site perfusions and vascularity. How the technology has essentially evolved is on the right hand side. We have seen this multiple times, wherein this is the illuminated ureteric catheters, which also required a near infrared system for us to delineate the ureters. But what you're seeing on the left and the right is the left one is showing the ICG technology without the overlay mode, which we saw in the Firefly, wherein when we activate the NIR system, the entire thing becomes black. And sometimes it does not help us like actually operating, because we can momentarily see, but then the surgery has to continue without the ICG application. So that is where the technology has evolved. Evolving even more further is the Rubina system, which has something what we call as the signal intensity mapping. So this is a case of early endometrial CA, wherein we are injecting reconstituted ICG dye superficially at 3 o'clock and 9 o'clock at 1 mm of the cervix and at 1 centimeter depth. Probably 1 ml, that is a total of 4 ml is sufficient. One important thing out here is that when you're doing early endometrial CAs or onco surgery and you're using ICG for sentinel node mapping, do the sentinel node sampling at the very beginning. Because if you go ahead with hysterectomy after you have injected ICG, finish off the hysterectomy, and then go to the retroperitoneum and the lymph nodes, we'll see suddenly that everything is showing a green uptake. So here the uterus is as it is preserved. We are following the lateral oncologist approach, that is of opening the retroperitoneum. That is, it is opened from the round ligament in a parallel fashion to the IP ligament. We are in the triangle between the external iliac vessels, the IP, and the round ligament. And this orange color hue which you're seeing is not the fat. That is the signal intensity, which tells us that green is relatively lower uptake, vis-a-vis an orange or a reddish color marks maximum uptake of the ICG, and it is this area that we need to biopsy. So it essentially, in early endometrial CAs, wherein we know that the side effect of performing a radical lymphadenectomies can sometimes lead to lymphedemas and various other complications. Plus, it might not be every surgeon's domain to do it with confidence. This limits our excision and makes the surgery safe and possible even for, early beginners. Now, benefits of ICG and near-infrared technology, as I already highlighted, is enhanced tissue identification, blood flow assessments, better surgical planning, reduced surgical time because we'll be minimizing needless over dissections, minimize risk of complications, and limitations, however, obviously is cost of the NIR system, and the availability of such camera systems itself is a big deterrent. accessibility, it has a slight learning curve, possible allergic reactions, and as I mentioned, depth of penetration. So depth of penetration, very funnily, when you take the scope very close to the structure which you want to see, it does appear green, whereas when you take the scope away, you might see no green hue. So that is another limitation, that being away, you might not be able to see the green when you want to. So finally, I just want to end by saying and conveying a very important message, that the art in minimally invasive surgery is not surgical bravado. It is not how much I can do. I can do peritonectomy for an absolutely needless case wherein there was no requirement of removing the entire peritoneum. Do needless retroperitoneal dissections and needless ureterolysis when it was not required. The art in minimally invasive surgery is learning and making it even more minimally invasive with the same efficacy and safety for our patients. So, as the possibilities with better understanding of this technology and with applications which I am learning day to day, newer applications, some have used it in the rectum to delineate rectal nodules. So, with broader applications, robotic integration and use of AI, sorry, uh, to analyze fluorescent patterns, I urge all of us to go green if feasible and minimize the morbidity by doing radical, needless dissections. Thank you so much.
Thank you so much, sir. That was a fantastic presentation, sir. And we all had fun listening to it.
Thank you.
So, thank you so much to all the dignitaries present here. And as I have also checked the portals, and there are no further questions from the participants. So, Monica ma'am, should we conclude the session?
We can conclude. Thank you all speakers for taking your time out on a weekday and participating. We will always be having more webinars. So please stay tuned and participate. And thank you, viewers, and thank you from all our AFG family. Thank you so much.
Thank you.
So, thank you so much to all the dignitaries. Planet is really glad to have all these brilliant people together in this session today. And thank you so much for extending us the opportunity to host the session. And I hope you all had a seamless experience. So, with everyone's permission, I'm concluding the session in here for today and looking forward to host you again. Thank you so much. Good night.